Greetings and welcome to the second day of our workshop on allocation of COVID-19 monoclonal antibody therapies and other novel therapies. We're very pleased to be able to host today's session, which is sponsored by the Standing Committee on Emerging Infectious Diseases and 21st Century Health Threats of the National Academies. I'm Harvey Feinberg, chair of the committee. We're very grateful, especially to the Office of the Assistant Secretary for Preparedness and Health in the Department of Health and Human Services, who have invited us and requested this workshop as part of an effort for us to prepare an expert consultation about the critical issues that we were discussing yesterday and today. I want to thank Dr. Kadlik, the Assistant Secretary, and his colleagues, Chris Hassel and John Redd, especially for their service and their contribution to the workshop and to the efforts that we have underway at large by the Standing Committee. Yesterday, we had a fascinating overview of the topic. We heard particularly from Marta Wosinka about getting the right treatment to the right patient in the right place at the right time. A great way to formulate the overarching challenges. And we had an opportunity to hear from a number of outstanding state and local leaders about the approaches they are taking in a principled way to attempt to deliver on the promise of monoclonal antibody treatments. Today, we have an opportunity to delve more deeply into some of the ethical issues about equitable distribution of this limited resource, the monoclonal antibody therapies. We're also going to have an opportunity to hear on a number of related and critical issues, including capacity to produce additional therapies beyond what we currently have available, the data requirements to collect additional information to learn more precisely and accurately about when, how, and with whom to use these therapies, and a number of critical global issues. This is not limited as a problem in any way to the United States. For the purpose of our discussion, we would invite all of the participants who wish to raise questions to do so with the Q&A function. We'll do our best in the course of the sessions today to take advantage of your questions. And I can assure you that even if we don't get to them with the panels today, they will be very helpful to our standing committee as we come to grips with the issues that have been raised yesterday and will be through the course of today. It's now my great pleasure to turn to the moderator and facilitator of our first panel, Dr. Alta Charo.
Thanks very much, Dr. Feinberg. Appreciate that. I'm Alta Charo, and I'm a professor of law and bioethics at the University of Wisconsin. I'd like to welcome you to our first panel, which is going to focus on challenges for ensuring equitable distribution and access and use and outcome with regard to monoclonal antibodies. We are going to have 11 panelists, each giving a 5-minute comment. So, this is going to be the speed round if we were in a game show. We're going to start first with 4 people speaking to general considerations in equity as well as institutional considerations. I'm going to introduce all 4 of them now, and then we will have the presentations in order, followed by 4 more speakers who will be touching on specific populations that are marginalized, disadvantaged, or have had disproportionate burden from this disease. And then finally, 2 speakers who will be speaking to some of the proposals for ethical frameworks for distribution to ensure access. So our first speaker is going to be Dr. Robert Goldstein, infectious disease specialist, as well as the medical director of the Transgender Health Program at Mass General. And we'll definitely be picking up on that particular issue about transgender health when we move into the Q&A. After that, Keith Boyle, who's the Chief Quality Officer for Population Initiatives at the Geisinger. as well as Christian Ramers, Assistant Medical Director for Research and Special Populations at the Family Health Centers of San Diego, speaking to federally qualified health center experience. And then Andrew Schumann, Associate Professor at University of Michigan Health System and Co-Chief of the Clinical Ethics Service for the Center for Bioethics and Social Sciences at University of Michigan Medical School. And he'll be speaking to challenges for institutions. So if I can turn it over first to Dr. Goldstein, please go forward.
Thank you so much, and good morning, everyone. I'm Dr. Robbie Goldstein. I'm an infectious disease physician, as you heard, at Mass General Hospital up in Boston. And I have perhaps today the most depressing role on this morning's panel. And I think that's because my goal is to really demonstrate to you all of the problems that we face when it comes to equitable access to monoclonal antibodies. And then I get to turn it over to a remarkable group that will be, I think, more positive, and will share with you some innovative solutions and really tremendous programs across this country that are doing the hard and necessary work of getting treatment out to thousands of people diagnosed with COVID-19 each day. So I'm going to start by giving us a bit of a lay of the land and highlighting that underneath the numbers that we hear about each day in terms of COVID diagnoses and COVID deaths is an important, nuanced, and real historic reality of inequity in our country. As of yesterday, CDC reported over 16 million American cases of COVID-19. And this week, we crossed a very important threshold of over 300,000 deaths. We all know that these numbers are shocking. And we all know that when we dive deeper into them, we're presented with real disturbing racial and ethnic disparities. If you are Black, if you're Latinx, if you're Indigenous in this country, you are approximately 4 times more likely to be hospitalized with COVID-19 and 3 times more likely to die from the disease than if you're white. You're more likely to have lost your job. You're more likely to have lost your health insurance or to not have had it before the pandemic even started. And you're more likely to have lost the safety net that a year ago may have been present. Now, these inequities are not just seen in the COVID-19 pandemic. In fact, the Kaiser Family Foundation recently published data that confirmed the fact that to be Black in America, to be Latinx or Indigenous in America, is equivalent to having barriers to access for healthcare. Unfortunately, but honestly, your race or your ethnicity in many ways determines if you can be healthy in this country. Now, these inequities are on the front page of our newspapers every day, and they should be driving policy decisions at the federal, state, and local levels. And it's these inequities that we are trying to address today, and in some part in our use of monoclonal antibodies for COVID-19. I think to fully understand our path forward with monoclonals, we have to understand what came before. And throughout the pandemic, we actually have drifted from the standard operating procedures of medicine and science, the publication of data from randomized controlled trials that drive diagnostic and treatment decisions, to a fairly new process of pre-publication news releases, rapid preprint distribution, resulting in changes to our, quote, standards of care. When data on remdesivir were first available, we heard of them through a press release, prompting just days later an emergency use authorization by the FDA, followed nearly a month later by publication of the actual data. Data from a trial that underrepresented Black and Latinx participants, given the rates of infection in those communities. And what followed from the sequence of events was fairly predictable. Hospitals and clinicians were tasked with providing a limited supply of a medication without knowing which patients might benefit most, without knowing if the drug achieved a mortality benefit, and importantly, without knowing if vulnerable communities would have trust in the system. And in the absence of a thoughtful, government-led, equitable distribution of the medication, hospital systems attempted to fill the void in grassroots efforts, working together to ensure that the drug was available to patients most likely to benefit. It's this experience with remdesivir, and I should say also with convalescent plasma and immunomodulators and novel antivirals, that serves as not just a warning shot, but a predictor of what may happen with monoclonal antibodies. Only I feel that with monoclonals, the danger is bigger. And when remdesivir was approved, Gilead, its manufacturer, quickly released enough doses to treat 78,000 people, with promises of hundreds of thousands of more doses in the months to come. It's still a limited resource, but the emerging data suggests that only those with severe disease will benefit from the drug. And we know that less than 5% of total COVID cases require hospitalization, leaving a sizable but limited subset of patients who would benefit. Monoclonals, on the other hand, are useful for those patients that are well enough to remain home, having their benefit early in the disease, or for those diagnosed in the outpatient setting. Distribution of these limited drugs needs to be widespread. It must anticipate shifts in virus transmission. It needs to make its way to supply outpatient clinics, and it has to be available for many of the 200,000 people that are diagnosed daily with COVID-19 that don't require hospitalization. And despite the enormous potential, only 250,000 doses have been delivered, and even fewer have been infused given limitations in workforce capacity and infusion centers. Problems that are even more evident in our rural hospitals and safety net hospital systems that lack many of the resources needed. And you're going to hear over the next 2 hours a really robust discussion about monoclonal antibodies focused on the decisions around distribution and patient selection, responses in the community and in academic settings, specific interventions in vulnerable populations because of race and age. And it's incredibly important that we have this discussion because we know that failure to address these issues will intensify the numerous challenges that healthcare systems have faced throughout this pandemic. It will result in a repeat of shortcomings and failures with achieving an effective and equitable response. And importantly, it will only exacerbate the disparities in care and outcomes related to this very deadly disease. With that, I'm going to pass it on to the next speaker, and hopefully we can lighten up the mood with some innovative solutions.
Thanks very much. Appreciate that. Keith Bowl, you'd like to begin?
Hi, happy to. Can I just ask if everybody can hear me?
You sound great.
Excellent. Thank you, and thank you, Dr. Goldstein. That was an amazing introduction. So good morning. My name is Keith Bowl. I'm from Geisinger Health. Real quickly, as an FYI, Geisinger Health is an integrated delivery system located and serving populations in northeastern and central Pennsylvania. That includes hospitals and a very large primary care and specialty network. We have a very diverse geography we serve, including urban areas such as Scranton, Pennsylvania, which most people know from the office, as well as very, very, very rural communities. We like to say we serve everything from our clinics have everything from a bus stop to a buggy stop, and it's very true. I also want to preface my comments by saying that throughout the pandemic, we have really taken a whole community approach to serving the communities that we're privileged to serve. And we've looked at this where we don't want to just treat previously established Geisinger patients, and that's included our work around monoclonal antibodies. We really want to get these into anybody that they can help. I'm really going to focus on the kind of front end of the process, which is how do we, and this will build on some of the comments from yesterday, which is how do we figure out who the right patient is and how do we get them scheduled? And one thing to remember as I talk about this is time is absolutely of the essence with this. The emergency use authorization includes that we need to get them treated within 10 days of symptom onset. And I think many of us, including here at Geisinger, are working under the assumption that the earlier in the disease course that we can treat patients, the more likely they are to have a good response to the medications. So talking about finding patients and thinking about the different elements of the emergency use authorization, one obvious is that they have to have a positive COVID test. And I think it's really difficult for me to think about how we're treating patients and how we're trying to find the patients with monoclonal antibodies without talking about some of the struggles we continue to have with testing. We have testing centers located across our footprint. We've worked very hard to try to integrate these into our communities. And again, we're offering testing to anybody who walks into them, whether they've ever been seen by Geisinger or not. And they could be just traveling through our area, and we're happy to test them. We unfortunately still have some delays in getting patients scheduled. We saw this after the Thanksgiving holiday, and we did see a fairly large spike after Thanksgiving. We're also continuing to see some delays in testing. We do part of our testing internally, but many of our testing, especially our ambulatory testing, we use a reference lab. And it can take anywhere between 2 and 4 days for the results to come back. And that's absolutely precious time to getting these patients scheduled. Once we have the test back, we had a pretty robust debate about the most equitable way to reach out to patients. And we heard in some of the examples yesterday that it sounds like there's a few ways to do this. One is that you could depend on a referral program where typical to how we do many treatments, providers could refer patients in. The other would be having a centralized outreach program where you identify patients who would be eligible and have people call and schedule them. We debated this, trying to figure out what the most equitable way to do this, and decided to go with the centralized outreach program because we thought if we relied too much on the referral process, it would really be the providers who either advocate the strongest or get there first. And we wanted to really figure out how we could treat the patients across our communities in the most equitable way. So we've embraced the centralized outreach program. We are exploring a referral program, especially as our capacity increases, but we haven't been able to do that yet. Key to our outreach program is knowing who's high risk. So one of the other things in the emergency use authorization is it defines several conditions that for which patients are high risk. And this includes patients who are greater than 65, patients who have different diseases, such as diabetes or immunocompromised, or patients who are greater than 55 and have things like cardiovascular disease, hypertension, and or lung disease. For us, since many of these patients that we're testing and offering treatment to are not cared for within the Geisinger system, we have very little historical data on these patients. And I think many of us are familiar with how terribly fragmented our healthcare data system structures are. So for patients who are cared for within Geisinger, especially at our primary care sites, we know what their BMI is. We know if they have diabetes or not. We know if they're on chemotherapy. But if their only encounter with the healthcare system is at the testing site, we really don't know any of those things unless we're collecting them at the testing sites, and our testing sites are very, very busy, and we historically have not done that. We are working to put those in place to try to narrow this gap. But it's a big data gap that we've really been struggling with. Because of this, we started with the risk factor that we knew we measured reliably within everybody, and that's age. One thing we do collect for everybody is how old they are. And greater than 65 makes you eligible for high risk for by definition of the EUA. So we've started by focusing on that population since we know that, and we didn't want to tip the scales towards patients that we know more and more. We are working very, very hard to start collecting more information at our testing centers so that we can offer additional therapy to patients. The other thing we did is, again, we serve this diverse geography. We have clinics and hospitals that can be 4 or 5 hours apart from each other. So we set up regional testing centers with the goal being that for patients to be able to have reasonable access to one of our testing centers. Again, some of our communities are very, very rural. So it may be a bit of a drive for some. And then some of our communities are very urban where people need to rely on public transportation. Which is difficult since all of these patients have COVID. But we do offer the outreach in 3 different regions, hoping we can get people scheduled where they can access the treatment in a reasonable fashion and not have to travel very, very far. Compounding this, I suspect people have seen the news. We got 2 feet of snow last night, which is actually fairly atypical for December in Pennsylvania. So we have the weather to think about as well. And it's clearly the current snow and the current storm is clearly impacting our ability to infuse patients. So once we have the patients we're going to reach out to, an additional difficulty is reaching the patients and having reliable phone numbers, which we try very hard to do. And the outreaches have some pretty difficult questions. Again, time is of the essence here. And if patients and if a patient isn't going to take a spot, which we want them to, we want to be able to offer that to other patients. And we really debated how many times do we call a patient? How long do we give them to decide? And these were difficult questions that we really grappled with, and we continue to revisit. I'll end with the conversation itself. I've actually spoken with several of these patients. And this is a very difficult conversation to have with patients. First off, the patients have COVID and they're scared. With everything else going on. And these are often patients that I do not have a previous relationship with. Actually, all of the patients I haven't had a previous relationship with. The other aspect of it is we thought it was very important that patients understand what we're offering them. And we incorporated a lot of the aspects of the emergency use authorization in the fact sheet into the talking points when we schedule the patients. We do provide the fact sheet when we infuse the patients as is required, but we wanted to make sure they understood what they were getting into. And these are difficult questions. As Dr. Goldstein just mentioned, there's a lot we don't know about these medications. They are clearly experimental. And we want to make sure our patients understand that, and explaining these concepts to them in a way that they understand it is very, very difficult. We feel like we're getting better at it. As we do it more and more. We worked with our marketing, legal, and ethics team to try to frame this in a way that patients would understand it. But it is a tough conversation to have. So I'll stop there. Thank you for this opportunity, and I look forward to hearing the other speakers.
Thank you very much, Keith. Much appreciated and very, very helpful. Our next speaker is Christian Ramers from San Diego.
Okay, I'm going to try to share my screen. No, I guess you'll share for me. There we go. Okay. Thank you so much for the opportunity, Alta, and thank you for holding this forum, this very important discussion. My name is Christian Ramers. I'm an infectious disease physician based in a FQHC, a federally qualified health center in San Diego that serves about 200,000 underserved and impoverished individuals very close to the border. I'm going to start with some basic points and then just discuss the disparities that we've seen racially and ethnically and geographically in San Diego, and then end with a little bit of optimism. Dr. Goldstein wanted us to look at the cup half full, and there have been some recent developments that are actually encouraging to me. With some basic principles, I'll start by saying that there's been a lot of attention on hospitalized patients, but the vast majority of COVID-19 is actually diagnosed in the community and managed in the outpatient setting. In our basic statistics, only 5% of people with COVID-19 are hospitalized. And so federally qualified health centers and outpatient clinics really bear the burden of management of this illness. And as up to now, we've had really very few tools. It's clear, I think, to everybody that cases, hospitalizations, and deaths have disproportionately affected people of color in communities of lower socioeconomic status, as Dr. Goldstein outlined. And I mentioned there's been a real focus on ICU management, but upstream interventions really have great potential to decrease the burden of hospitalization if deployed strategically with high accessibility and in heavily affected communities. Also, as Dr. Goldstein set the table, there really has been no large-scale strategy. And so the reality in our community of community-based testing is just as fractured as our healthcare system always has been. We as a large FQHC network have really stood up a lot of testing. We're sending now 500 tests a day and diagnosing 80 to 90 people with COVID-19 per day. And we really have the highest chance of linking the chronic medical care of these individuals to the COVID testing results, knowing their medical history, knowing their BMI, and really being ideally situated to give these therapies. Up to now, it's been very difficult to assess whether the distribution has been targeted, impactful, or equitable because it really has not been transparent. I have a list of where the doses are going, but nobody really knows how to get them. No one knows what's been given and what populations they've been given to. Next slide, please. And then let's advance a couple more times. There we go. Okay, and maybe one more time. There we go. Okay, so this is a model of the COVID-19 disease course that has been proposed really early in the pandemic, that there's an early viral response phase. Most patients are in the outpatient arena during this time. And it's really not until the host inflammatory phase kicks in where patients get really sick and hypoxic. And of course, that's where all of the drug development really is focused, or at least the approved drugs so far. And we have this big gap here in the outpatient arena that really has no interventions thus far. But if you advance one more time, of course, these new monoclonals are really what's going to fill this gap and really where we're focused on today. Next slide. So I came across a couple of pieces of literature that really, I think, explain what's going on here. And this goes back to the 1970s by Hart et al., the inverse care law, which is that anybody working in an FQHC knows this to be true, that the availability of good medical care tends to vary inversely with the need of the population being served. This was kind of updated with the inverse equity hypothesis, also published in The Lancet, that stated newly introduced health interventions will be initially adopted by wealthier segments of a population who likely have the least need. And in the short term, absolute health inequalities will increase and only decline as the intervention gradually reaches the most deprived sectors of the population, by which time coverage among the most privileged sectors was already close to 100%. As an infectious disease specialist, I've seen this with innovative HIV therapies, HIV prevention with PrEP, hepatitis C therapies. It really kind of goes across the board. And one of my own personal idols, Paul Farmer from Brigham and Women's in Boston, has said that any serious examination of epidemic disease has always shown that microbes make a preferential option for the poor, but medicine and its practitioners, even in public health, do so all too rarely. Next slide, please. So the San Diego County Public Health Department has been publishing both cumulative COVID case rates by zip code as well as the most immediate in the prior 2 weeks. And we've seen persistently an obvious geographic disparity where the cases are highest closer to the Mexico border where Tijuana is, and they sort of trickle down and are stratified and get lower and lower as you get into the more wealthy areas of northern San Diego County and up into Orange County. Go to the next slide, please. If we look at published reports of hospitalizations, cases on the top left, hospitalizations on the bottom left, and then deaths, there's really a clearly persistent disparity such that Hispanic Latino populations, which comprise about 32% of the population in San Diego, yet have been making up 57% of the cases, 57% of the hospitalizations, and almost 50% of the deaths, really truly the definition of a health disparity. And on the bottom right, this is an unpublished paper, but coming soon. If we look at all-cause mortality and look at excess deaths of US-born Latinos, Mexican-born Latinos, and Central American-born Latinos, very much higher excess death rates that we've seen in San Diego since the beginning of the pandemic. Next slide, please. So with the National Academy of Sciences workshop on equitable allocation of vaccines, it was emphasized that using social determinants of health, such as the CDC Social Vulnerability Index or the California Healthy Places Index, both which aim to use 16 to 20 upstream parameters to show poverty and socioeconomic status, that these patterns really geographically mimic where COVID is being impacted the communities in the worst way. And yet on the far right, I've listed the hospitals that received Bamlanivimab and Regeneron monoclonal antibody doses, which clearly show a predilection to the northern part of the county where the resources are actually the richest. So you see a real disparity to where these doses are going. And as I mentioned, there's really been no transparency in terms of who's getting the doses. But I think you can clearly see from these maps and all of these little turquoise dot points there in these hospitals that it doesn't really match where the disease is having its biggest impact in the communities. And my final slide. So I'll just conclude with some thoughts, and I will say that as an FQHC, we have not been involved in infusing monoclonal antibodies. However, I've convinced the county to start allocating us some doses, which should arrive this week or next. It's been a little bit of a stretch, but it's nice to see that things are actually pivoting towards being a little bit more transparent and equitable. I think, in my own opinion, monoclonal antibody allocation was initially quite rushed without sufficient attention to equity. There are signs that Operation Warp Speed seems to be pivoting into more equitable considerations. I think this forum is actually an example of that. The story in San Diego of having the county be responsive to allocation and actually sort of change the way doses are allocated, I think is encouraging. And I will say that FQHCs are really quite well positioned to test and identify underserved communities with high-risk patients most likely to benefit from the therapies given the limited supply. Many have demonstrated the capability of bringing on new infusion centers. There's a FQHC in Los Angeles that was really a pioneering in this respect. And the whole point is that we are part of this and we can do our part to keep people out of the hospital. Just as we've seen with testing resources and as we are seeing currently with vaccine distribution, monoclonal antibody allocation, really the managers of the allocation must actively work to avoid this inverse equity hypothesis where new interventions really only reach those that are least in need. And thank you for the opportunity to speak.
Thank you very much. That was terrific. The last person speaking in our first cohort is going to be Andrew Sherman from the University of Michigan. Please.
It's a privilege and a pleasure to be here. Thank you for having me. My goal is to talk a bit about the role of allocation and equity from the standpoint of a university. So I work at the University of Michigan and am one of the clinical ethics faculty who is working with issues related to scarcity and distribution. I'm going to talk briefly about three specific components of this process. The first is indication, the second will be transport, and the third will be screening. From an indication standpoint, we are all operating under the same federal rubric through the EUA for these medications, and certainly cannot extend those indications more broadly. And this was discussed yesterday by many of the speakers. However, one challenge that institutions have when dealing with issues of scarcity is whether to be more restrictive with our access to monoclonals and other scarce medications than specific indications that are coming from FDA. With the monoclonals, this has been particularly difficult because our goal is to provide these drugs to whomever might benefit, but to restrict them in some way, at least, for those who perhaps may be at a higher level of benefit. This is dynamic by nature of the fact that we don't necessarily know how many patients will be diagnosed or eligible each day or each week, and also our supply will vary. And based on a great deal of research in the market of drug shortage and scarcity, which is not a new issue, we know that waxing and waning supply will always complicate matters of allocation, distribution, and rationing. As a result, we have an incredibly dedicated and hardworking team working to dynamically adjust our indications in order to utilize the supply that we have without necessarily exhausting it for patients who might be diagnosed tomorrow. One of the operational challenges at a large institution is that these allocation decisions are often made by a dedicated team of stakeholders, but are also vetted through a scarce resource allocation committee. And by nature of the rapid changes in supply and demand, we need to be adroit and able to make those changes on a day-to-day or week-by-week basis. And the structure, which is in place for very good reason to ensure issues of equity and transparency and due diligence, very well may hinder the ability of those at the front line, who are indeed the content experts, to make those changes in real time and make that possible. So one issue that we've dealt with at a large institution is how much flexibility to give the dedicated experts to make those changes in indication when it comes to issues of scarce drug. The second issue that I'm going to briefly talk about is transportation. Again, this has been already and will be highlighted during other aspects of this session, but it is incredibly difficult to ensure that indigent populations who may not have access to their own car, or quite frankly, not indigent populations, but anyone without access to their own car, can safely get to an infusion center. And like every other institution, we had to very quickly create an outpatient COVID infusion center that was safe. We also had to put it in a geographic position that was accessible to our patient population and not necessarily only people of higher means or higher socioeconomic status, but also available to others. But also to realize that access to a bus stop, for example, is less important for a COVID infusion center than it is for other aspects of medical care in a way that we really haven't necessarily had to think about. So as we all know, we don't necessarily want people with COVID to be jumping on the bus, but we also want to make sure that they can access an infusion center. So our institution, like others, worked very closely with a ambulance and transport service to contract to try to provide access to outpatient COVID monoclonal antibody therapy, even if they were not necessarily able to drive to those sites. This in and of itself brings up significant issues of logistics, finances, insurance, and others added to all of the other burdens on a system that this pandemic has caused, but I would argue is an incredibly strong and compelling need to make sure that those who don't necessarily have a car can still access this treatment. And we will be hearing a bit later about home infusions, which are also another fantastic opportunity and option here, but are also mired in logistical and insurance-related challenges. Those can be dealt with, but this is an ongoing problem for many. The other issue I'll bring up is one of screening. And this has been alluded to by Dr. Boll and others already, but it is incredibly complicated to dynamically screen and vet every new diagnosis of COVID to determine eligibility for the monoclonals. And the challenges herein have required an institution like ours to essentially use a full-time FTE pharmacist to screen and vet every single case. And the heroes of this are at the front line, the people who are doing this work. But this is incredibly time-consuming and challenging work to not only screen every positive case, but as was alluded to earlier, figure out who has comorbidities and who doesn't. Of those who have comorbidities, who has a car and who doesn't, how to notify these people, and all within a few days in order to get them their infusions as quickly as we can. Another issue that we've dealt with is the fact that we are diagnosing people within our system who may not necessarily receive healthcare or have primary care providers within our system. And another challenge that we've had has been to determine what our cutoff is, so to speak. So is everyone who's diagnosed and whose test result we're made aware of eligible for an infusion? As a result, these complicated matters have led us to think of new barriers to equity and access that we are taking into account. I look forward to the discussion and would be happy to explore these issues further. Thank you.
Thank you very much. It's a rather daunting challenge that you all have laid out for us. We're going to turn next, and by the way, we will have time for questions among the panelists and hopefully also from people in the audience, but we're going to go through all of the presentations first. So for our next group of presenters, we're going to focus a little bit more closely on specific populations and get a chance to delve a little bit more deeply. Our first speaker is Abigail Echo-Hawk, who will be speaking about the concerns that relate to the indigenous populations. The next speaker, and forgive me in advance if I've mispronounced your name, will be Anika Sederstrom, who is the Director of Clinical Ethics at the Children's Hospitals and Clinics in Minnesota. Then Robin Stone, who will be, who's the Senior Vice President for Research at Leading Age. And then finally, Connie Sullivan, who's the President and CEO of the National Home Infusion Association. Please, Abigail, we'll have you go first. Thank you.
Thank you, Alta, and all of the great speakers coming before me. As she said, I'm Abigail Echo-Hawk. I'm an enrolled citizen of the Pawnee Nation of Oklahoma and hold dual citizenship here in the United States as both a citizen of a tribal nation and in addition as a citizen of the United States. And as we talk about the disparities that exist within racial and ethnic minorities, it's really important to get some of the information. So when we think about the population I serve as the Chief Research Officer at a federally qualified health center in Seattle, serving American Indians and Alaska Natives, and also the director of the only tribal epidemiology center that serves Native people nationally. We know that Native people are 3.5 times more likely to test positive for COVID when compared to non-Hispanic whites. We also know that we're approximately 2 times more likely to die. But if we take a deeper look into that data, we're actually finding things that haven't been highlighted. Our younger populations are experiencing deep disparities. And in fact, in a recent MMWR, in which I'm a co-author that was released last week, we found for younger ages, and I'm going to point out one specific age group, ages 30 to 39, they were 11 times more likely to die than their non-Hispanic white counterparts. Yet, when we look at these disparities, we're finding that very few American Indians or Alaska Natives are receiving or being offered the treatments that were just discussed. And the question that often comes to me is why? And most people will point out, oh, it's because most Native people are living in rural areas. It's difficult to get these treatments, lack of providers. And my answer is yes, but. Because we know that more than 70% of all American Indians and Alaska Natives are living in large urban settings like Seattle, like LA, like New York, like Denver, across the country. It's not just a rural issue. And if we look at our large urban population, they're also not receiving these kinds of treatments or being offered these kinds of treatments. And we know that part of that comes from the lack of outreach, the lack of understanding, and also the deeply entrenched systems of systematic, institutional, and individual level racism that our people experience every day. So when we look at, for our Native people, when they look at these treatments, when they hear about them, one of the things that we know that there's very little data of American Indians and Alaska Natives in these kinds of treatments. We have not been included in clinical trials, not only for these treatments, but also for the COVID vaccine treatment, COVID vaccines that are currently have been released. We have not been included in the clinical trials, and both at the NIH level, at the pharmaceutical level, they have not been good about ensuring that there's proper representation of American Indian and Alaska Native people in these clinical trials. And as such, our people are hesitant to participate in something that has none of their evidence in it. So my organization, in looking at how do we discover what our people think, how can we give them more information on these kinds of treatments? So we launched a survey recently, and I'm going to share just a little bit of the preliminary results, just one. When we gave them a little bit of information about these treatments and asked them if offered this, if they had had a positive COVID diagnosis, would they participate if they were offered such a treatment? And our preliminary results are showing that more than 70% would participate if they had actually been offered this kind of a treatment. However, anecdotally, because there is no data on it, we cannot even find a Native person, and I work nationally across the country and I'm very deeply connected in our communities. The folks of us who are working in this area, we can't even identify American Indians or Alaska Natives who have been offered this kind of a treatment. And so when we look at, again, the question why, we know that identifying American Indians and Alaska Native is high risk. We are and very often are at high risk for comorbidities, hospitalization, and death, that there's very little data that is represented within hospital medical records. And in fact, we find the most up-to-date research shows us that more than 30% of American Indians and Alaska Natives are either racially misclassified within hospital systems data, or there's no race or ethnicity data for them at all. And as a fact of this being invisibilized within these hospital systems, the providers who would be looking for things such as identifying their American Indian Alaska Native, then looking at other risk factors, aren't being able to do that because the data in the systems don't exist. And this racial misclassification is an issue that we have been pushing for and fighting for many years, and however have seen very little change in the way that race and ethnicity is collected within EMR systems. So these barriers, the mistrust that exists within our communities, again, go back to this system of racism that has created health disparities and is perpetuating the deaths of my relatives every single day. So I think back to some of the barriers related to COVID-19, and I have a personal story in the FQHC that I work for in February when we were asking for PPE, being the epicenter of COVID. We had no PPE, and we had our lead physician was actually sewing fabric masks for the rest of our staff. We asked for that from our local, our state, and our Indian Health Service partners. And instead of receiving PPE, we received a box of body bags. That, even though it actually did happen to me, is a perfect metaphor for what's been happening across American Indians and Alaska Native communities. These barriers, which are systematic, whether it be access to transportation to get to treatments, whether it be access to just being offered, this is something that our people are not receiving. And instead, what they have grown to expect is a box of body bags in this metaphor versus actually receiving the treatment that they should. Equity requires us to change that, and it's going to be disruptive, it's going to be uncomfortable, and I am telling you, it is absolutely not voluntary. We need to look at how the distribution of these treatments are and look at facilities such as federally qualified health centers serving minority populations and low-income populations, and in particular, Indian Health Service facilities, who are the ones these communities trust, where they have the clinical ability to provide these kinds of treatments, and the social services to wrap around them and to support them in moving forward in these services. We have to look at this as an issue of equity. And right now I'm struggling in COVID of how equity has become a catchphrase versus an action. We have to be vigilant for these consequences of the decisions that are being made around COVID-19, who receives treatment, who doesn't, who gets tests, who doesn't, who gets a body bag, and who gets treatment. Equity is fundamental to the community we want to build, and we have to get uncomfortable and challenge the status quo. And I'll leave with you this last thing again, I'll say it again. Equity and these looking towards reaching that for populations most effective cannot be voluntary and has to be not a catchphrase, but our every action.
Thank you, Abigail. And I think that image is going to stay with all of us. Our next speaker is Anika. Anika Sedestrom, please.
Hi, thank you everyone for the opportunity to join this panel and to speak a little about inequity. And I thank the previous presenter because she set up my talk just very eloquently without even realizing. As we are aware, the COVID-19 pandemic has affected Black and Brown communities within the United States harder than any other groups. We know that the reasons are based on the fact that these populations of people tend to be in environments that are most at risk and tend to have pre-existing conditions, making them the most vulnerable. The why is simple, yet complex at the same time. It's because of racism, and the fact that racism is the normal, everyday state in which all the systems and structures within America operate, from housing to environment, to access to food and access to medical resources. We know that there is a major difference between how white Americans live and how Black and Brown Americans live. It is impossible to discuss issues around inequity without addressing the reality of systemic and institutional racism. In regards to thinking about how to make access and distribution of monoclonal antibodies and other novel treatments around COVID-19 to be more equitable, we must first have to address the reality that equity requires conscious, deliberate, and intentional thought. Some of the most problematic issues that were raised yesterday around the distribution of monoclonals is that it's difficult to operationalize. In rural areas and other low-income communities, it is a significant problem to try and find a physician or a clinician who would be able to make a patient referral in a timely manner, let alone have access to an infusion center that is set up to maintain safety of others while infusing infectious patients. Our history is full of examples of why members of the Black and Brown communities have not and still do not trust the medical community. We still have yet to reconcile that history and own it. To try and offer a new therapeutic intervention that has not shown strong efficacy data and does not have a huge bang for the buck to a community that at baseline is distrustful of all interventions due to historical trauma is a recipe for failure. In addition, there is a real concern of additional charges and copay fees that we know these communities are not able to pay. The populations that may benefit the most are usually the ones that are often ignored when we look to set up new structures and standards. We fail to take into consideration the very real reality of living in a society built and sustained on racism. In some of my previous work on inequity and COVID, I highlight the fact that we've built our models on crisis standards on philosophies that are Eurocentric, inequitable, and racist at baseline. We are now trying to work towards alternative modeling and try to reconcile that, but without pushing for intentional and deliberate frameworks, we won't be successful in those efforts either. We have to acknowledge that in times of scarcity and crisis, our default is to try to be more controlled and unified. The struggle with that default position is that in our society, controlled and unified are states seated in racism and inequity. We have to actively go against the grain to move from controlled to intentional. And that is why the answer to how to incorporate inequality into this work is often met with a sense of being too hard or too distracting to do during a pandemic. We have to work on that. It must be a distraction we are willing to engage in order to truly have impact. It can't be a side project that we pull out when we think now we have the time to work on it. We must be willing to change the norm of inequality and be intentional. Doing that will not result in some lopsided favoritism to push one group over another. It will allow for the cosmic gap to shrink a little and to help move us one step closer to a truly leveled playing field. As we work through the nuances around monoclonal antibodies, we must do so with this reality as our guide. Otherwise, we're doing nothing but maintaining the status quo of inequity. The work lies in better understanding what strategies need to be developed in each area to operationalize equity. There is not a one-size-fits-all option when it comes to this work. Some places are working through developing what I've called a give-back approach to attempt to account for disparities deliberately. Others are looking at bigger access points like the area of deprivation index to use as a proxy for decision-making. I don't have the answer on how to make this work for everyone, but I do know that it is a requirement. Even if the only level is at of systemic change is at perceived at and measured at the institutional level, that would be a great step forward. We must join together to make everyone realize that equity is their work, not just the work of those who have it in their title or think it's the right thing to do. When we are all better at understanding how our own individual actions continue to perpetuate and maintain the current oppressive system, we must act otherwise unless we agree to be co-signers of that oppression. Maya Angelou stated it perfectly when she said, "Do the best you can till you know better. When you know better, then do better." Right now, we need to do better. And I look forward to further discussions and questions. Thank you.
Thank you, Anika. Very much appreciated. Our next speaker is Robin Stone.
Sure. Hi, thank you. Can you hear me?
Yes, we can hear you very well. Thank you.
Okay, great. I am really happy to be here, and I'm going to try to be quick and to the point. I'm Senior Vice President for Research at Leading Age, which is a national association of over 6,000 aging services providers. And we represent the entire spectrum from post-acute, nursing home, assisted living, home care, adult day, the whole range of everything from all the non-acute and post-acute care that's delivered in this country. And I want to say a couple of things because this builds on the last two speakers. I'm going to talk about three populations today that are at really high risk, and they are a microcosm of all of the issues that you have heard so far. The first is our long-term care and post-acute population, living in nursing homes and assisted living. The second is our home care and home health population of older adults and younger people who actually have not received the attention of late that finally the nursing home population has received. And then the third, and probably the most at risk, are the workers who actually provide 60 to 80% of all the services across all of these settings. Over 5 million aides, certified nursing assistants, home care aides, home health aides, who are at very high risk and who really need to be part of this discussion around how do we equitably distribute resources. I would say in addition to racism, we have a huge ageism problem in the United States. And this was absolutely identified when the first cases came out in Washington state and nobody recognized that there was going to be an epidemic, a pandemic in nursing homes and other congregate settings. And that continues to this day. We are struggling every single day to get PPE, to get testing, to get contact tracing. Vaccines now that are starting to be distributed. It's a nightmare out there. And I worry about that same thing for these new therapies. And I want to talk about a couple of issues around that. First of all of these folks are at very high risk. And there is very little data, particularly on the very frail elderly who are living in nursing homes and other settings because they have not been included in clinical trials. So it is very high risk for them to actually be receiving these treatments and to be part of the guinea pig populations. And as AMDA, which is the Association for Post-Acute and Long-Term Care, has written a letter to the federal government and to CDC to ask for some delays around these treatments because there is very little evidence in terms of how they work and what are the iatrogenic effects of these treatments. So in terms of thinking about administration, we also have to think about the lack of data in terms of actually even administering these drugs. So that is one issue. The second issue has to do with thinking about how do we look at state allocation and the distribution of these very scarce resources. And I would argue that we know that long-term care and the LTSS system has a large overrepresentation of folks who could potentially benefit from these treatments. And they are not on the first priority radar list. They're second and third in all state allocation, below the hospital systems, for example. I personally believe that a lot of the distribution should have been focused on the long-term care system and the home health and home care system from the get-go, and that hasn't happened. So the distribution at the state level, I think, is really important. And then the question is, how do we administer these treatments? Should they actually be efficacious for these populations? We know that you cannot get an older adult who is living in a nursing home or assisted living to go to an infusion center. So the need for serious partnerships at the local level, and I know we're going to hear about IV infusion centers, but I really believe very strongly we need partnerships between public health, home health, and infusion to actually figure out how we equitably get these treatments to our nursing homes, to our assisted living, to our other residential settings. And then just as challenging, more challenging, is how do we get our home care folks who are at very high risk. These are people who have multiple comorbidities as well as mobility challenges to actually get to centers. I'm optimistic about the future role of home infusion and the role of home health to actually bring this into communities. But I'm also concerned about the allocation and the distribution of those resources. And just as concerned, I am really worried about the AIDS, because these are the folks who have transmitted these viruses in these settings. They go back into their community and then they spread through the community. How do we actually think about allocating resources to these frontline AIDS? 30% of these folks are immigrants. Over 60% of all AIDS are non-white. They are African-American, they are Latinx, they are indigenous populations. They are a part of everything that you have heard so far. This is a microcosm of the challenges that we have in the allocation and the administration of all of these treatments. And I actually think it provides us an opportunity to learn from this microcosm of how we figure out how we equitably distribute resources and administer these resources to the most vulnerable and the most high risk, who are elderly, who are people of color, people with comorbidities, people who are lower income, people who have very little resources, transportation to be able to get to access to these resources. So I look forward and I'm quasi-optimistic that maybe with these treatments and paying attention to these very vulnerable populations, we will have some success and some lessons learned for the future. So thank you.
Thank you very much. Appreciate those comments. Last speaker on special populations, at least at this point, is Connie Sullivan.
All right, thank you very much. And Robin, thank you for that perfect segue into my slides here and what I want to discuss with you all today. I am Connie Sullivan, as she said. I'm the president and CEO of the National Home Infusion Association. I'm also a pharmacist and have spent my entire career in the home infusion industry, which is more than 25 years. So I'm really delighted to be part of this important discussion today. So thank you for the invitation. Just a little bit about the association. We're a fairly small industry, and we represent the home infusion providers, suppliers, and companies that provide products and services to home infusion patients. We represent about 350 companies, which includes about 1,000 individual pharmacy care providers and over 11,000 clinicians who provide these services directly. And just to give you some context about home infusion and the size of the industry, about 3 million patients annually receive infusions in the home setting. And for those of you who may be not familiar with home infusion, let me give you a little background on how the services work. We provide a wide range of therapies for both acute and chronic conditions that can be infused in the home. The vast majority of home infusion patients come to us after a hospital stay and continue an IV antibiotic or parenteral nutrition or an inotrope after having some sort of exacerbation. But 10% of all of the patients that receive home infusion are receiving some sort of biologic therapy, whether that's for immune deficiency or a chronic autoimmune disease. So we are very familiar with infusing products like monoclonal antibodies in the home setting and have established protocols for doing so safely. Home infusion is generally something that comes into the picture for patients who are going to need prolonged IV therapy. So generally we are developing relationships with these patients because they need an IV, but they are otherwise stable enough to be self-sufficient at home. And honestly, most patients learn to do their own infusions for the non-biologics. So these are patients that become very proficient in managing their IV access, and with the support of pharmacists and nurses, become very independent, managing their therapy and go on to live fairly normal lives. We span all payer sources, and when we're talking about equity, I want to make the point that Medicaid does cover home infusion in most states, and so we are successful in reaching that Medicaid population, and all home infusion providers take some amount of indigent type work and work with hospitals on reaching patients that have no payer source whatsoever. And we have a wide range of provider types in our industry. We have hospital-based home infusion providers, big national companies with multiple locations. But when we look at the type of provider that can reach these more underserved patients, it's really those single site independent providers that are in more rural settings in a lot of cases, or they also can be in urban areas that are often serving the most challenged patient populations and do the highest percentage of Medicaid. And then we serve all age ranges as well. 0 to 99 years of age were represented in our most recent patient satisfaction study. So I want to talk a little bit about the unique challenges that Bamlanivimab creates when we start discussing home infusion. And I completely agree with some of the other presenters today that home infusion represents a major opportunity to reach some of these patients that are maybe less inclined to visit an institutional setting. But when we look at how we could do this, and we are facing some hurdles as an industry. First and foremost, this one-time infusion makes it a little bit difficult for home infusion providers to recover their upfront cost. Obviously, this also involves a substantial amount of nursing time when you start going one-to-one with a nurse to a patient in the home setting. And while I like to say home infusion can help many patients, but there are limited capacities, there are some patients that will only be helped by home infusion. And there are many patients, as Robin was discussing, that are homebound or have, it's a significant effort to transfer to a centralized location for an infusion. And all home infusion patients require a fairly significant onboarding process. You have to work out every detail of how that infusion is going to be administered before the nurse and the drug are delivered to the patient's home. And one of the resources I think home infusion providers have, which I think Dr. Schumann referred to earlier, is an infrastructure for that comprehensive assessment that has to happen to see if a patient meets the criteria for these therapies. Home infusion providers have multidisciplinary intake departments that basically do an assessment top to bottom of the patient's home environment, the therapy that's prescribed, the patient's clinical condition, and this is typically staffed by pharmacists and nurses and reimbursement experts. So that alone, that resource of being able to do that intake process in home infusion is something that states, I think, could more readily tap into. And in home infusion, because we have limited capacity, could be diverting patients to other sites if a patient is able to go to a field hospital or a hospital center for the infusion. We certainly want to direct them to the most appropriate site of care. There are a lot of one-time costs also associated with home infusion, with anaphylactic kits and supplies, PPE, et cetera. One of the other barriers is that a lot of the patients that we're talking about today don't have a primary care physician. And obviously, home infusion providers are pharmacies. We respond to prescriptions and orders from physicians. And so we need processes for getting over this hurdle for patient populations that may not have a physician who can refer them or write the order. And I like to think of a model at the state where we can fill in that gap that's similar to what we've done for naloxone therapy. For patients that have been qualified in some other way, the state could have a standing order in place that the pharmacy could then move forward with, so we don't waste valuable time trying to find a physician who can do an assessment and move the patient forward. As of right now, also, I think it's important to just acknowledge there is no allocation for home use. Home infusion providers do not have allocations for providing home infusion today. So the drug is simply not making it to the home infusion providers. And then secondly, payer sources other than Medicare have not worked out the reimbursement rates for these therapies. And then again, obviously, nursing is a limiting factor. So in the spirit of talking about what we can do, I want to mention just that we have been developing these partnerships with long-term care facilities and through the SPEED program at Operation Warp Speed. to have home infusion providers go to long-term care facilities and help support them in delivering these products. And NHI has played a key role in this by providing the information to our members about this opportunity, collecting information from them, verifying their license and accreditation status, and then sharing that with HHS as well as information about how to allocate product to them. And then they're reaching out in their local catchment area to promote the program, and the response has been overwhelming.
If I may, I'm so sorry to interrupt you. Just to find out how many more slides you happen to have, because we're trying to keep on schedule.
I understand. This is it. This is my last one.
Thank you, and I apologize for interrupting.
No problem. So in the first week of launching the program, we had 144 individual pharmacies respond, and we allocated 560 doses in the first week. And that was because they wanted to see what kind of interest there was in the program. And in this week alone, we have already had many providers ask for much larger allocations, and the interest has extended beyond long-term care in prisons, dialysis centers, et cetera. So that's my slides for you. Thank you very much for your time.
Thanks very much, Connie. And again, I apologize for having to interrupt. We've just got too much material and too little time. Our last two speakers are going to speak directly to some of the possibilities for ways to ethically allocate. First speaker is going to be Doug White from the University of Pittsburgh, followed by Govind Prasad from the University of Denver. Doug?
Wonderful, thanks, Alta, and thanks to the academies for convening this really important workshop. So I'd like in the next few minutes to describe the weighted lottery approach that we developed and implemented in Pittsburgh, Pennsylvania to allocate scarce COVID-19 medications. One of the main goals of which is to mitigate disparities in COVID-19 outcomes. Next slide, please. And I'd like to start by emphasizing what I think is a really important point for policymakers to consider when developing allocation frameworks for scarce treatments, which is that overcoming access barriers, although critically important for fairness, won't actually mitigate disparities. The best outcome you can really hope for with overcoming access barriers is to prevent a widening of existing disparities. But to actually mitigate disparities, it will be necessary to direct more resources to groups that have been disproportionately affected during the pandemic. Next slide, please. So you may wonder whether disparity mitigation is an appropriate ethical goal when allocating scarce COVID treatments. And I think the argument is quite strong that doing so is ethically appropriate. Recognizing that there's not adequate time for a full defense of this claim, I'll just say a couple things about why. First, allocating scarce COVID-19 treatments during the pandemic is a public health intervention that is overseen by states during a public health emergency, which is to say it's not a clinical intervention. And therefore, the ethical goals of public health should be the goals that guide allocation. And what are those goals? Well, Larry Gostin has beautifully articulated them when he wrote, "Twin moral impulses animate public health: to advance human well-being by improving health, and to do so particularly by focusing on the needs of the most disadvantaged." Next slide, please. And what you see in this statement is a focus not only on promoting population health outcomes, but also mitigating disparities. Next slide. Another way to conceptualize this equity focus is through the lens of equal respect, which is to say we show equal respect for all members of society by mitigating the negative circumstances that cause disadvantaged persons to bear the greatest burden during the pandemic. Next slide, please. So to accomplish these goals, in May 2020, we convened a multi-institution consortium of experts from bioethics, economics, health disparities, medicine, pharmacy, and health law. And this group initially developed the allocation framework I'll present for remdesivir. And unfortunately, we had to use it in the UPMC health system for about 6 weeks when demand far outstripped supply. And now we're prepared to use a similar strategy to allocate monoclonal antibodies should demand outstrip supply. And I want to especially acknowledge Professors Sonmez, Pathak, and Unver, our economist colleagues at MIT and BU, who were really quite gracious in simplifying down their elegant categorical reserve systems to something that non-experts could deploy in the very time-pressured circumstances of acute care. And just to note, this allocation framework was reviewed and endorsed by a patient and family advisory council in Pittsburgh, and also endorsed by the Commonwealth of Pennsylvania in their allocation guidance to the Commonwealth. Next slide, please. All right, so what is the weighted lottery? Well, the first point is that every patient who meets eligibility criteria has a chance to receive the drug. The baseline chances for patients are determined each week when a shipment of the drug arrives. And we do this by dividing the number of treatment courses in hand by the predicted number of patients who will be eligible that week, which is based on the prior week's numbers. So for example, if there were 100 treatment courses and 200 expected patients in that week before the next shipment is expected to arrive, each patient's baseline chance to receive treatment would be 50%. And on top of this, we added 2 weighting factors focused on equity. First, frontline workers receive a 25% increase in their chances. And note that this is not just healthcare workers, but it's lower paid workers like grocery store clerks, bus drivers, and food services workers who are disproportionately persons of color. And second, patients from disadvantaged communities also receive a 25% increase in their chances, and this is defined as residing in a neighborhood in the highest quartile of disadvantage, quantified by a measure called the Area Deprivation Index. Next slide, please. So we deployed this weighted lottery across the UPMC health system, which is an integrated delivery system with 40 hospitals, 700 outpatient clinics, and 7 skilled nursing facilities. And in the last couple of weeks, we've been able to stand up capacity to administer infusions to more than 300 patients a week at 19 infusion sites across the state, including at all 7 of our skilled nursing facilities. Next slide, please. So what did this look like operationally? And this is my second to last slide. Well, with the goal of achieving equitable access and increasing efficiency, we centralized the lottery process as well as centralized the scheduling of infusions. So when a request comes in, the Pittsburgh allocation team confirms eligibility with the treating physician and then conducts the lottery. And it's important to note that the staff running the lottery are blinded to all patient attributes except those factors that inform the weighting process. The referring physician is informed whether the patient is allocated the drug. He or she gains consent and then hands the patient off to a centralized scheduling office that helps the patient schedule a time at a nearby infusion site. And I think critically important, we're following all patient outcomes through medical record review, including subsequent ED visits, hospitalizations, and 30-day mortality. Last slide, please. So the final point I'd like to make is that a secondary benefit of using a centralized lottery to allocate monoclonal antibodies is that it has tremendous potential to increase our knowledge about the treatment's overall effectiveness. And in my view, this is a critically important goal right now in light of the, frankly, very thin evidence base on which the EUA rests. So how does this work? Well, in the face of scarcity of treatment, the lottery's primary purpose, as I said, is to achieve fair distribution of the scarce resource. But the lottery also introduces randomization into the allocation process. In other words, the lottery, which is motivated by fairness, also creates a natural experiment. And by following the outcomes of patients both allocated and not allocated the treatment, we can make valid causal inferences about the treatment's real-world effectiveness. And as we argued in this JAMA perspective, this process is most powerful when the lottery is centralized in a state or a region, because doing so allows potentially thousands of patients to be followed in a single registry. So I'll close by saying that I think weighted lotteries are an important tool to respond to scarcity in ways that give all eligible patients a chance to receive treatment, that mitigate disparities, and that can add to our knowledge about the effectiveness of these novel treatments. Thanks very much.
Thank you very much, Doug White. And our final speaker for this section is going to be Professor Prasad from the University of Denver.
Great, thank you so much. So I'm going to be presenting some work in collaboration with Professors Monica Peak and Seema Shah at Northwestern and University of Chicago. And what we really started off with here is trying to think about the existing NASEM principles for vaccine allocation. We thought these were thoughtfully developed and reflected some widely shared values. So these principles are, and many may be familiar with them, especially here, maximum benefit, mitigation of health inequities, and equal concern for people who might be recipients of an intervention. So next slide. So yesterday we heard from a lot of thoughtful local and health system decision makers about what we might call micro allocation within a health system or jurisdiction for these monoclonal antibodies. And one of the major, probably the most common strategy that I saw was trying to use what we might call medical criteria, narrowing the existing EUA criteria. So many systems are saying, well, we'll use a stricter age cutoff, say, or give priority to people who are older within the pool. Use number of comorbidities, or adding new criteria. So one group, I think in Wisconsin, mentioned adding sex as a criterion. The goal here, although it's not articulated explicitly always, I think, is to try to increase the benefit. There are a couple of problems here that I think are worth investigating. So one of the big problems, which the speaker, Dr. French from Colorado, identified yesterday, is that there may be a lack of evidence that there actually is going to be greater direct benefit from narrowing within the EUA criteria. The other is that, which I'm going to focus on, is that narrowing may not mitigate and may exacerbate inequities while not necessarily getting to more benefit. So let's go to the next slide to talk a little bit more about that. So here I have a map of Chicago where my collaborators are based. And I want us to think about, I have flagged here a census tract in Chicago where the average life expectancy is 67. And in some of the presentations yesterday, we saw folks saying, well, if there's a scarcity, we'll just go up to age 75 as the priority or inclusion criterion. This is just an illustration of how narrowing can present a problem, just using age as an illustration. So starting out, right, we know that there are major disparities in harm among middle-aged, even below 65 minority patients. As Dr. Echohawk talked about this, Mary Bassett at Harvard has a great paper really laying this out in depth in PLOS Medicine. We know about the intersection here of racism, of economics, so people under 65 who can't get Medicare or Social Security yet and are exposed at work, people who are exposed in housing, not just in long-term care, but in other sorts of multi-generational or crowded housing situations. We also know that there are disparities in life expectancy. So going back to the slide, this county with overall life expectancy of 67, we know from MMWR data that recently there's about a 10-year disparity in average age of death among decedents. So 72 among non-white, non-Hispanic decedents versus 81 among white decedents. Adding other ways of narrowing can compound this. So sex can compound this. If men over 80 are at the top of the list, given the shortest life expectancies among minority men, that can further exacerbate inequities. Undiagnosed comorbidities are another challenge. Doesn't mean you can't look at age or sex or comorbidities. So you might say, but you need to acknowledge and counterbalance these inequities. And so one step you might take then is you might say, look, instead, let's use a lottery. The challenge with the lottery is that even though it doesn't exacerbate inequity, it doesn't intentionally actively mitigate inequity. If there's really a lack of evidence about direct benefit, it makes sense to try to intentionally promote equity and also to look at indirect benefit. So let's go ahead and go to the next slide. So we suggested applying the NASEM principles to monoclonal allocation by picking out priority groups to try to achieve greater indirect benefit and also to intentionally mitigate inequities. So to give priority to folks in the NASEM's groups 1A and 1B, so urgently scarce health workers and other essential workers, to try to mitigate inequities indirectly, and also to try to maximize benefit and indirectly. If you have scarcity of staff, which a lot of folks have talked about, you can get a major multiplier effect, especially say in rural areas where one provider may be a keystone. Also using SVI to define a priority group to mitigate inequities directly, so using the social vulnerability index. We suggest implementing this through what's called a reserve system. The speaker from Massachusetts talked about this yesterday. You can have about 50% priority for 1A, and then smaller priority for the other groups. You could adjust this. So you could have more SBI priority if you wanted, and you could add a general population category. So this is one way of trying to operationalize intentionally, leaning into mitigating inequity as opposed to just trying not to exacerbate it. So I'm all done. You can go to the last slide.
Govind, did you have a last slide that you wanted to talk about?
Yeah, this is the last one. This was the macro issues. I wanted to underscore that we think jurisdictions can have different systems. We don't have to have a one-size-fits-all answer. Different jurisdictions are in different places. So.
Thank you. Thank you very much for those. We have a tremendous amount of material. I've been keeping track of questions that are coming up in the Q&A, and I'm going to try to capture some of those. But before I do, I wanted to take advantage of Dr. Goldstein's experience to just check in on one more population, and that's the LGBTQ population that may or may not have some special considerations here. So if Dr. Goldstein is available, I'd like to invite him to just make a couple of quick comments.
Absolutely. I'll keep this very brief. I'll first say that we actually don't have much data on sexual orientation and gender identity when it comes to COVID-19. Individual states and municipalities are trying to collect some of these data, but nationally, we don't know what's happening in the broader community. But I do think that what we have to recognize and what we're talking about today in all of these discussions is trust in the healthcare system and whether these vulnerable, marginalized populations trust healthcare. And we know from longstanding data that the LGBTQ population in general, and in particular the transgender community, and certainly those trans folks from communities of color, have very low trust and faith in the healthcare system. In our own personal experience here at Mass General, we have done what we can to continue to bring transgender and LGBTQ folks into the hospital when necessary, but it's been very challenging actually in the COVID environment to build that trust and to build that faith in the system, to get them in for the testing they may need, to encourage them to enroll in clinical trials so that they can be included in data analysis, and to bring them in for emergency use authorization treatments like remdesivir and now monoclonal antibodies.
Thank you very much. I'm really glad that we were able to get that included in the conversation. We're going to certainly be getting to some of the issues that are particular in terms of logistics and outreach, particular to these kinds of populations, as well as the systems for allocation that we were just hearing about. But one question that's come up in the Q&A in various forms is what I would call the Woody Allen problem. You may remember in one of his movies, he had a couple of women talking about a hotel where they complained that the food was so bad and the portions were so small. We've heard a number of people make mention that the efficacy data is not as strong as we would like. And at the same time, we're talking about the need to actually make sure everybody can get this. So I was wondering if we could have anybody from the panel who'd like to just raise their hand and we'll let you speak. Speak to the degree to which there is kind of an ethical or social obligation to absolutely manage this equity issue given this lack of efficacy, or if that in any way changes how we think about this problem. I'm going to switch to gallery view so I can see all of you now, and I'll open it up just for conversation. And I'll Christian and then Govind.
Yeah, I'll start just with a stab at the efficacy issue. Of course, we want more data on these products. We just have very limited phase 2 publications thus far. But this, in my view, meets the definition of what an emergency use authorization is for. We have a reasonable belief that the product may be effective. There are no other alternatives out there. And given the crisis that we're in, this is exactly where an EUA, I think, is appropriate. In addition, the main outcome that I think this therapy can have is of extremely high value in our current situation. Southern California, we're at 0.5% ICU capacity. So the value placed on avoiding a hospitalization is incredibly high, even though the data may be very uncertain. So that's my take on the efficacy part of it. And I think the other panelists have really illustrated that the implementation really has been very, very problematic, just in terms of reaching the populations that really need this therapy the most.
Thanks, Christian. Govind?
Yeah, I think this really underscores, in terms of thinking about a multiplier effect, I mentioned providers being one area of trying to address this urgent scarcity. I think research, yesterday we heard so much about how we don't know that much about who within the EUA group benefits the most. If you're able to allocate these in ways that don't interfere with ongoing trials, and if you try to work harder to have ongoing trials and to have diverse recruitment into those trials, the future value of that information, just based on what we heard yesterday, could be really big. So I want folks to think about, I agree with the fact that we don't just stop in the face of no information, but research here isn't just a sort of issue of better outcomes. I think it's an issue of better equity as well.
Anybody else? Yeah, Abigail.
So as we think about, in particular, the last comments in regards to clinical trials, and I've worked in the area of clinical trials myself for many, many years, and folks are like, you know, we have such a hard time recruiting American Indians and Alaska Natives. And I was like, well, I've worked on more than 30 clinical trials right now. Not only did we recruit large enough sample size of American Indians, Alaska Natives, we over-recruited. What we did, though, was partner with the community and build strong relationships and maintain those relationships and ensure that they knew the risk and the benefits of those clinical trials. And what is missing and has been missing from clinical research is that community connection. And it's also missing in part because the funding doesn't often allow for it. And so we kind of juggle how we do that. But it's not that the populations won't participate, it's they haven't been asked in the right way and the relationships have not been built. When I look at the success of the clinical trials I've been a part of, it wasn't hard for us. And that's because we are ingrained in the community. And so we need more of these clinical trials to be reaching out to community practitioners, to the communities themselves, and building relationships to ensure that the data is properly representing those who should be represented, instead of writing your letter to the NIH that says why you didn't reach your 25% mandated racial, ethnic, and gender minorities, you know, that they require for you to do. Stop doing that. And instead, we need to truly make those efforts to build these up so that the data is represented. And in regards to getting the treatments to people, the thing that we're finding in our community is nobody's asking them and nobody's offering it to them. We need people, even though their data is not in the clinical trials, even though some of the data is pretty scarce, they still need to receive that same option that other people are receiving. They still need to get that transparent information so that they can make a choice for their own health and well-being.
Thanks, Abigail. I know Anita would like to say something. I'm sorry, Robin. I know Anita put her hand up, and then Robin. And if I'm missing anybody because I didn't see you, please just send me a direct message in chat so I don't miss you. Anika, then Robin.
Yeah, so I just wanted to clarify and just kind of tackle onto what Abigail just said, actually. I feel like what we tend to do is we tend to just do the, oh, well, we tried and then we just didn't get the numbers, right? It's just, or it's too hard to engage in the community because of history. And because we want to get the trial going, we only have a certain amount of funding and we have dates and deadlines that we want to hit, we excuse it away. And we don't take the time and the effort needed to build the relationships that have to happen. And as a result of that, we miss out. And this relationship building work it's hard. And it requires that intentionality that I was speaking about before. There must be people who are willing to go to these community, to go to community leaders, to go to people who are from that community who do this work also to help bridge the gaps in order to better understand how to access those communities for research. They are not anti-research. They have not been asked, or they don't feel like even being asked. The way they're asked is being respectful of who they are, the cultures that they come from. We tend to feel like there should be just a one size fits all prescriptive measure of how you should do clinical research, but there is no one size fits all culture within this country that would agree with that. I mean, the methodology in which we use is very much based off of white American culture. It does not include things like community leaders and community elders of how they see and engage in families with decision making. It doesn't include historical traumas. It doesn't include how in many of being in Minnesota, there's often a lot of problems within our Somali community. Doesn't include religion in a way that needs to be explained and expressed in order to allow for people to feel like they can join in trials. I think that we just don't do a good job of truly addressing the fact that people are made up of more than just their ethnicity. And they have culture, they have community, they have religion, they have other ties that pull into why they will enter a community trial or not. And we need to do better at really seeing people for who they are and then bringing that forward. Otherwise, we're never going to hit that 25% mark, and everybody will have a standard template that they send to the NIH, and we'll still be in the same bucket that we are now. Thank you, Anika.
Robin?
Yeah, I just want to quickly say that I think at some point, now I've worked in aging my entire career. So, I think that we absolutely are going to have to deal with the question of equity and aging and longevity and scarce resources. I mean, elderly people have been not in many clinical trials over the years. People with dementia, there are so many exclusions in clinical trials drugs that are used on the elderly were not actually tested on with the elderly. And I think there are issues around productivity and quality of life and who should get what. And I think we have to have some really honest discussions again around these equity issues. I would add age into this. You know, within the next 40 years, children who are born now, they're expected to live until 100 if you're white and fairly, if you're in a certain category. There's a lot of inequities there. But I think age is also a question of how we deal with this. And implicit in some of the discussions are really, should we be giving these drugs to people who are likely to die within 2 years? I think that's a really important question. On the other hand, a huge proportion of the deaths during this pandemic occurred in people who live in nursing homes. Should we just let these people die? And I do think that we need to think about this in clinical trials because there's so much inequity and age is one of those factors. So I just wanted to throw that out because I think we often skirt around it. And I think it's a big issue for the academy. I'd love to see us deal with this more.
So, again, trying to kind of pick up on a lot of the things that are going on in the Q&A, there have been a lot of these comments about specific considerations that are particularly pertinent to one particular subgroup versus another. We've also heard in the discussion, for example, where Doug was presenting on his weighted lottery, the value of having a kind of centralized system for identifying priorities. And yet at the same time, operationally, we're hearing from the people who are talking from the institutional perspective about the many, many individual factors that go into this. So I wonder if I can just open it up for conversation here about the kind of balance of discretion and flexibility that would be appropriate, keeping in mind we're trying to deal with the mitigation of inequities, as between a kind of centralized or formalized set of guidance that really controls who gets what and when, versus kind of bedside decision-making and discretion at the level of the provider. Obviously, they're both going to occur, but how do you see the balance here, keeping in mind the institutional issues and the particularities of the subpopulations? And again, I'm trying to look at everybody. If you put on your video, if you're on the panel, I'll just be looking for people who are waving their hands.
So I'll take an initial stab. I think this really comes down to the resources. And the hope would be that as this emerges and as the supply of the medication gets better, and which our experience to date isn't that the medication is the rate limiting factor. It's really our ability to give it and to find the patients. So the hope would be as we catch up, and we heard a lot of this yesterday, and we're able to infuse more and more of this medication, it'll be a balance of both. I think for us, we started with the central because we thought it was the most equitable way to do it. And it also was a little bit logistically easier, especially with the time. I mean, most of the people, when people get referred for therapy, it's usually not, have them in a chair getting a new medication the next day. I think the person who described giving it at home did an excellent job of just how logistically difficult that is. The hope would be, though, as the weeks go by, and I think what we'll see, and we heard, I think many people yesterday, Northwell did a great job talking about it, where we're standing up these COVID dedicated infusion centers while we're considering giving the medication, or I shouldn't say considering, we're able to give it more and more in facilities to vulnerable populations like those in nursing homes or rehabs or SNFs, and potentially being able to give it more and more. The hope would be that the capacity then meets the demand and we can have a balance of both. I don't think it'll ever be one or the other, because I think if it's a pure referral system, patients will fall through the cracks. I think that happens right now with many, 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 many things. And I think, though, I think that said, if it's a pure centralized outreach, you have a lot of those data issues that that a few people talked about, where we just can't find all the people.
Thanks. Very much appreciate that. I've got Doug and then Connie.
Thanks. So I think that when we talk about the centralization versus discretion question, one way to think about it is, and in my view, a reasonable way to think about it is that there should be centralization, perhaps at the state level, maybe even more broadly, about what are the ethical goals of allocation. And that we shouldn't leave to individual clinician discretion to come up with new ethical goals. And where the discretion could come in at the health system level or even broader is, what's the mechanism by which we try to achieve those goals? Because I do think there are really legitimate questions right now about whether stratifying or narrowing based on clinical criteria versus using a weighted lottery versus using a categorical reserve system are just unanswered questions. And there's value in some different approaches being used around the country.
Thanks. We have Connie and then Andrew.
Yeah, thank you. I think the concept of centralization probably works better in an institutional setting than it will work in the community setting. When you're talking about trying to help individual providers at the local level who have scarce resources for nursing primarily, decide, where do I send my nurse? Is it better to send one nurse to one patient's home, or use that nurse to go to a skilled facility where I can have that nurse infusing multiple patients in a single room and helping the most high-risk patients? I think what in addition to centralization could be useful here are just guidelines that we could publish and give to individual providers. Most of our providers are required to have an ethical review board, and they want to have these discussions. They want help making these decisions. But ultimately, right now, the reality is that they're on their own to come up with these solutions. And while states can play a role in the allocation process, I think you also have to think about, how do you make the decision on the ground when you get to the patient care process? And in what we're finding, unfortunately, is that home infusion is not part of the discussion at the state level in the allocation process. They're not familiar with home infusion. They don't know how to connect to the providers. And that's one of our goals, is try to help close that gap so that they know who to reach out to in their communities that can provide these services, and start having those discussions with them about what their capabilities are. Thank you.
Thank you, Connie. I've got Andrew and then Robbie.
Yeah, I want to second Dr. White's comment related to using a rubric and applying that rubric. And one fundamental component here is the importance of consistency and transparency in order to engender and build trust, exactly as has been alluded to as well. The other component here that we should talk about very briefly is that issues of inequity don't just affect patients, they affect institutions. And many of us work at institutions and within systems that are blessed to have scarce resource allocation committees, and many people dedicated nearly full-time to working on these issues, but many are not. And the guidance that may come from a state or other central organization may be invaluable to groups that don't necessarily have the wherewithal, time, money, or people to meet on a dynamic basis and reassess how this should be done. So I would second the importance of having centralized guidance, but also the need for institutions and other organizations to be able to apply them to their populations, so long as it's being done transparently and cogently.
Thanks. Robbie Goldstein and then Robin Stone.
I was just going to maybe pick up on this thread around trust, because I will say here at Mass General, we have gone with a more centralized approach in our distribution of monoclonals. We have a very large reach in our healthcare enterprise that encompasses most of the state in many ways. But what we found is that people don't trust the person calling them on the phone to go forward with the infusion. And that's the rate limiting step, not so much that we can't identify those people to make sure that we could, in theory, distribute monoclonals equitably. And we know this from other clinical trials. I can tell you as an HIV provider for many years, patients ask me all the time whether they should enroll in clinical trials and look to their provider for that trust and that faith in the system. We have to think about that in the setting of COVID, where these are rapid decisions that are being made in a very short time frame, where it may be challenging to get individual providers to build the trust that's necessary. But how do we actualize that centralized process so that we're still maintaining those personal connections?
Thanks. Robin Stone and then Govind Prasad.
Yeah, I just wanted to quickly speak to making sure in the decision-making process around this, who are the stakeholders that are going to be at the table? And, I've been in this for so long in the bastard child world of long-term care and LTSS, which most of the resources are frequently going to big health systems who make a lot of decisions without other entities at the table, including other parts of the system, including the CBOs that are in the community that know these various subpopulations. And So I think if you're going to have that kind of a decision-making process, and you're talking about transparency, you really need to be clear about who's at the table to help make those decisions. How often they get, I mean, we have so much token involvement of various stakeholders. And this is another example of a completely failed health system and public health system activity, every single one of these things. And so I think we have to think very well. I mean, it's great to talk about centralized and you've got, a decision-making process, but a lot of the decisions are not including the stakeholders who are really on the ground. So I just want to make that point.
Okay, and I was corrected by Gogan. So I'm going to just try to move this into another related area that's been coming up in some of the Q&A. Many people have noted that despite this concern about making sure that there's equitable access or access at all, that a lot of the doses are simply going unused. And we've heard yesterday, particularly, and a little bit again today, about some of the logistical challenges here. But I wonder if people have any thoughts about ways to get past that problem, particularly for communities that are traditionally underserved, how to particularly reach out and make these things available to those who need it. And I saw Christian put his hand up right away. Thank you.
Yeah, just a comment about trust and location. I think to address the comment about why the doses are not being used, we're seeing 4 or 5 separate private health systems get the doses and hoard them, and honestly just hold on to them. And I think there has been no real mandate to be transparent about who you're giving the doses to. So if that was implemented, then perhaps that would improve. And then just a comment on the previous thread about difficult to find patients or location or building trust. These are not difficult to find. Ask any community clinic who's doing COVID testing and you'll see their positivity rates are 30%, as they are in my community. And if you want to come in as a big academic medical center and try to build trust, you can't do that in a short period of time. How about depending on the FQHC that's been there for 50 years and has built 50 years of trust? I think this is just a really tired model that, it's the way research funding gets pushed out. It's the way a lot of healthcare gets pushed out. There are trusted community partners that have been there for a long time, and they should be the ones that are at the table.
Thank you. Let's see, I've got Doug and Connie that wanted to say something about this, and Abigail.
Yes, very quickly. I agree with Dr. Raymer's points around trust. Part of this issue, I think there are, honestly, I think there are trust issues at both the clinician level and the patient level. I think health systems and clinicians have been a bit leery to refer patients because there are legitimate questions about the efficacy of the therapy. And that's why I think, one target to address this is to quickly get better data about efficacy. Now, on the issue of patients' trust, I think this is a very vexing issue, and there are people on this panel much better equipped to answer that than me. But I think focusing on the trust level at the provider level and the trust issues at the patient level are both important.
Thank you, Doug. I've got Connie and Abigail.
To the question about why are more doses not getting utilized, I think it starts with the fact that one, state health departments are responsible for the allocation, and they really didn't see monoclonals coming. They are very focused on vaccines, and as they should be, and they have limited bandwidth to deal with something as complicated as a monoclonal antibody, and don't really understand the post-acute distribution model for those. Neither do the manufacturers of these products, unfortunately. Regeneron and Lilly, I think, are coming up to speed on what other mechanisms for distribution are besides hospitals. So I think ultimately what happened is, the states basically said, well, we're just going to allocate everything to hospitals and hopefully they will figure it out. Instead of tapping into existing infrastructure. And I want to commend Operation Warp Speed and ASPR for looking to alternatives to how do we get drug to community-based providers who can help distribute them to long-term care, assisted living. We need to add prisons to that. I think when you look at these types of IV drugs, the community providers for sterile IV products are home infusion providers and long-term care pharmacies. And even long-term care pharmacies may have limited capacity for sterile clean rooms and those types of facilities. And so when you look at who can do this and who can prepare these products and who has the distribution networks in place with nursing, home infusion is a key hub in that spoke that could be utilized more effectively. And we're starting to do that now. It's taking a little while to get those connections in place, but I think it's certainly an opportunity we need to continue to explore and try to educate states on. But understanding states clearly have their hands full, and we're happy to help provide that information.
Thank you. Abigail?
Yeah, so I agree with working with community organizations such as FQHCs. I'm an executive in an FQHC, and we did consider this just a couple of weeks ago, however, due to what we had been offered from our state. However, one of the things that weren't considered is the fact that as an urban Indian health program funded by the Indian Health Service, we have an incredible lack of space. I literally have a building that is falling down. And as a result of the restrictions of our funding from the Indian Health Service, again, rooted in systematic racism that is, affecting us, I can't use any of my dollars for facilities. We have to private fundraise for all of our facilities. And so I had no space for this. We had a lack of resources. We've had to completely change our space to meet the COVID precautions. And also, we closed one down, part of our clinic facility, to make open for COVID patients and COVID testing. We simply didn't have the resources in order to be able to do this well. And so these systems of inequity that have not properly funded community health are directly resulting in whether or not we can offer treatments like this at our federally qualified health center. And then we struggle with referring patients out to other facilities that can. So something I was dealing with last week for another issue, we sent a patient who needed to see a specialist. And when we looked at her chart notes, we found that the nurse who first interacted with her, instead of talking at all for the reason she was there, was talking about how she possibly saw track marks on her arms and how she needed to be referred to a social worker. And she was unsure on whether or not she was a good caregiver for her small child. So our people are experiencing this level of systematic racism based on the color of their skin. And so we are frightened to send them to systems outside. So all of these barriers are intersecting and interacting. But if I had had the facilities, it would have been a different story. If we had had the space, we probably would have done it. And so all of these other barriers, again, that are rooted in systems that have created these health disparities for marginalized populations, they're working. And they are effectively continuing to marginalize us.
Anika, and then after that, I wanted to raise another question before we begin to start running out of time. Anika?
Yeah, no, I just wanted to add that I think we also forget that the people who are behind these decisions, who are in charge of making the referrals, they're still people who operate in a system that they have not been trained to operate differently in. They were trained and grew up in a system that is rooted in racism, and they are trained to look at people differently and to act differently and to respond differently. And the assumption that we can just tell them to do it in another way is not going to work. We have to undo the training. We have to address the systematic racism. We have to address the disenfranchising of Black and brown populations. Without even the pandemic, we have all the data on how the disparities within these populations, with literally in every health problem that people face, are huge, and it has nothing to do with the pandemic and everything to do with the way our society is. So having access to the monoclonals, whether they're being hoarded or whether there's just no environment to be able to provide them because of the systemic issues that led to that disparity, it still goes back to the people who are in charge of this, the people who are thinking through structures and the ability to create an alternative path have not done the work themselves to understand how they are part of the oppressive system and how to fix that. And so I think that we can't move forward until we acknowledge and try and retrain our brains to be more sort of in line with our reality. We do things, we make decisions, clinicians every day decide one path for a patient versus another that is rooted in a system that oppresses others. And we haven't done a good job of addressing that. So we have to kind of go back to the foundation before we can look for some steps to be better.
So we're working on two different paths here. One is the more long-term, more fundamental and more widespread path, having to do with the things that Abigail and Nika are talking about. But in the short run, in the very narrow short run, with the admitted reality that it's a narrow and short-term issue, I wanted to raise the question about how to take advantage of what we're hearing here in order to improve on the efficacy data that we're getting specifically for these underserved or marginalized or disproportionately burdened populations. People have already mentioned that it's been difficult to recruit into clinical trials, that there's an absence of best information, whether it's for people who are racial and ethnic minorities based, or people who are at the older end of the age spectrum. Frankly, pregnant women have also had to be left out of the clinical trials. There are many groups that have been left out. So we've identified some groups here that we know need to have some special outreach in order to at least achieve some progress toward equitable access and use. What kinds of suggestions do people have for how to then do a better job with follow-up, so that at least in this post-approval stage, we have better data on how this is working that might be used by the FDA when the question comes, should they approve this for use outside of an emergency situation? And how do we make that data more representative of the full spread of society? Anybody have any suggestions? I see Robin, thank you. And you're muted.
That's sort of why I talked about the sector that I work in as a microcosm, because a lot of really bad things have happened in the LTSS sector, whether it's in a congregate environment or a home-based environment. And you've got a mix of very frail older adults and also a large workforce that is extremely diverse. They're primarily Black and brown people. And so I think we have an opportunity as almost a natural experiment to learn from this. And as a researcher, I've been so frustrated that we are not learning from, I don't really think we're learning, that we do all these different little studies. And I think there's a real opportunity, if we had pilots that really focused on the community that was around a long-term care environment, for example, and a home care environment that actually focused on all of these populations, we could look and see what happens to them. I mean, you've got to be able to find people. It's sort of like this is one of the keys under the light. And so we could be learning a lot more from them. We can put the methodologies together to actually get quicker information around efficacy, administration, implementation, all of those things. So that's one thing I have been thinking about, because we've got target areas around the country where we could be doing this and learning from it. And we're happy to help because we have thousands of communities across the country with all of these different populations either working there or suffering there. So, so that's my solution.
Thank you, Robin. I know Abigail, Christian, and then Connie, who had some information about the pilot projects that they're doing. So Abigail?
Sure. So although I've been talking about all of the bad things, and they have to be acknowledged, we always move forward in our communities in the sense of we wouldn't be here, we didn't survive, we intend to thrive within the United States. And so my team has been working specifically, I have staff who sit on the advisory boards for clinical trials that are related to these types of therapies. I have staff who are sitting on the oversight community outreach boards for the COVID vaccine trials. And the one thing I will say I'm really impressed with is these particular trials, they haven't treated that kind of participation in a token way. They have actively made the changes that have been suggested by my team and by others. And so by that true inclusion that isn't token, but is really implementing changes within clinical trials in the way that they're outreaching, we're going to be able to ensure inclusion as clinical trials move forward. And we are also working within hospital systems. And so we are working with some here in Seattle from the FQHC in which I work at. We are sitting down and talking to hospital systems and very specifically giving them our ask of them to ensure that our people are properly included including making sure that those folks are properly trained to interact and serve our people well. And so we are working towards that. And the other thing is what we've told them is, you know, we don't have a lot of free time, and you have a lot more time and a lot more money, and we expect you to pay us for this so that we can sustain this kind of community engagement. And that's what they're doing. So we're in the beginning stages of that. There are those opportunities there, but we need people, those who make the decision about the allocation of resources, about who sits on these clinical trial boards, and whether or not that advice is truly being implemented. And I'm seeing some of that, and it's really encouraging.
Thank you. We're just about at the top of the hour. I know that Dr. Sullivan and Dr. Goldstein have to drop immediately at 12, so I want to thank them in advance. And then I'd like to give Christian the last opportunity to say something before we have to end the session, unfortunately.
Just a comment on evidence generation and where we are now. It feels like convalescent plasma all over again, where an EUA really was the death knell for any high quality evidence. So it's very difficult to consider ongoing high quality placebo-controlled trials in this setting where there is access to the drug. But I would say that, you know, what can be done is in exchange for receiving this product, a minimum reporting burden, just to say who's using it, how they're using it, perhaps some follow-up data on who ends up going in the hospital. Not the highest quality placebo-controlled evidence, but at least it would be something. And we know from anybody that's had NIH grants, you know, the federal government is great at giving money and asking for you to report on it. And yet I don't really think this was done in this situation. So it is a burden on the people receiving the product, but we could learn something at least of how it's being used in the community.
Thank you. And Connie Sullivan wanted me to mention to everybody that they will be collecting data on all of their experiences and making all that data available. So that'll be another source for post-use information. This has been a wonderful panel. I'm afraid we can't solve all of the deeper problems and more long-term structural problems, but we've heard some very interesting suggestions for some short-term actions to take. And with that, I'm going to thank all of the panelists and turn this back over to Dr. Feinberg. Thank you.
Alta, thank you so very much. Let me add my thanks to everyone on the panel for an incredibly rich and informative discussion, wide-ranging across topics that I know will continue to resonate with us as we try to come to grips with the larger questions. We're now going to take a half hour for a lunch break on the East Coast and whatever other break elsewhere in the country. We're going to reconvene promptly at 1/2 the hour. So I look forward to seeing everyone or having everyone back with us at that time. Alta, thank you again for an outstanding job moderating.
Well, just making sure you can hear me okay.
Yes. Greetings, everyone. It's a pleasure to reconvene and to have you all back with us. We're now going to turn to our next panel, which is going to cover a variety of topics in the next hour and a quarter. And I'm very pleased to invite Donald Berwick to moderate this session. Don, over to you.
Thanks so much, Harvey. Yes, this is the Everything Else panel. I hope we won't get topic whiplash, but we have 4 topics that we'll be covering with the help of our fantastic panel. Cost of the monoclonal therapies, manufacturing capacity, and especially scale up, issues about data and evidence generation, and then we'll spend some time on a global perspective from other countries. So we have 9 panelists and not a lot of time, so I'm going to get right to them, and I know they'll stick with the time available to them. Marianne, are you with us now?
Yes.
Marianne, can you hear me okay?
I can, yes.
Okay, Marianne, if we can start with Marianne Hamilton Lopez, Research Director of Value-Based Payment Reform for Duke Margolis Health Center, Center for Health Policy. Please go ahead.
All right, thank you so much, and thank you for the opportunity to be part of such an esteemed panel. Today, we're going to talk a little bit about, in addition to the many logistical issues that we heard about most recently, that outstanding question of how will we pay for right now the administration of these types of therapies, and then also how will we pay for the therapies themselves once the public health emergency is over. So with that, we just want to give some thought, at least in this, my first set of comments that are just outlining some of the payment considerations. Next slide, please. So as you may have heard from my colleague Marta yesterday, as she was talking about making sure that the therapies are available to the right patients at the right time, Duke Margolis has also been thinking about some of the other components of the administration of these types of therapies, specifically evidence needs and then payment considerations. I've outlined here perhaps a wishful thinking about a potential COVID-19 population treatment pathway, one in which we would ideally have the right type of payment that would encompass the very complicated path from the testing itself to the infusion treatment, follow-up, and evidence collection. So seeing here that it would have sufficient funds for testing, that would allow something that's accessible, accurate, and timely, then onto the referrals of appropriate sites of care for treatment, and then the infusion administration and the data collection as the third component. Next slide, please. However, as we heard, especially in this last session, there are a lot of concerns that are really coming forth as we're trying to think through how to administer these therapies, and that these uncertainties will have implications for the payment. And one of those concerns is there's uncertainty surrounding the appropriate base payment mechanism. And Medicare has chosen to apply for the outpatient reimbursement rate, the same amount as the highest level for a complex chemotherapy infusion, and monitoring across all care and with no copays, and that's under its CARES Act vaccination authority. This base payment is $309 and some change, and there's just great concern that this amount may not be adequate, especially for all sites. Maybe, for example, it might be more appropriate in some of the larger health systems that have the capacity to absorb such cost. But for those other sites, such as long-term facilities, mobile home infusions, these kind of pop-up COVID-19 focused infusion centers, they're going to be having high cost in setting up the new infusion services and the need for providing a higher intensity care, as well as the needed additional PPE and personnel that may just not have adequate reimbursement with the $309. Also, as while we have a required Medicaid coverage, state payment approaches are not clear at this time. Also, there's a lack of support for longitudinal data collection and analysis of treatment outcomes, and that may hinder the risk stratification for new and recently diagnosed COVID-19 patients. Ideally, we'll get to a point with these new MABS treatments where there can be risk stratification and better decisions about who needs the treatments, how it's applied. However, there's no incentives within any of our payment approaches at this time to incentivize any sort of extra evidence base or evidence collection in addition to the payment for the administration itself. And then an overall payment issue is just a concern that the fragmented payment may prevent effective delivery of service across the continuum of services that would ultimately improve outcomes for new COVID-19 patients. If payment is fragmented across payers and sites of care, there's a risk that providers will not have the capacity to invest in timely referral networks for treatment after the testing and the safe and effective delivery of new infusion services. These payment issues are all especially true as we are under a public health emergency authority. There will be other considerations once this time is over. And for example, there may be more copays associated with the actual drugs itself, and that we will need to be thinking about now sooner rather than later. Next slide, please. I know that this slide is incredibly busy and not expecting anyone to really read it, although it is available in our most published paper on our Duke Margolis website. But what we've done here after a number of discussions with different stakeholder groups is trying to think through what are the various sites of care and what are some of the implementation considerations. We'll not do as great of service as those who spoke in this previous panel, but that we will have specific payment rate considerations for each of these sites. And it kind of lays out the case that there's got to be more considerations for each place, especially in the home infusion, temporary standing infusion sites and administration. Next slide. So my final slide here is just to say that we put forth a number of recommendations from our Health Policy Center. One is that payments providers should adjust. We might say we don't know enough yet to understand whether the payments for administration are adequate. We should know more, and that we should have the flexibility to adjust to support effective access for antibiotic treatment for all high-risk COVID-19 patients. Also, CMS should collaborate with states and HHS to track access to COVID-19 treatments and identify gaps. We also say that the federal government should consider funding deployable antibiotic administration capacity to hotspots and underserved areas, and that CMS and private payers should consider whether there should be a further adjustment of payment rates for test return time. Finally, something that we're further exploring and trying to see if there is a level of interest in whether or not we could tie some public and private and reimbursement that could support a limited core data platform, a registry for high-risk COVID-19 patients. So it would add the incentives for those who are being asked to collect this type of data, but ultimately to improve that evidence on how to best use the antibiotics in the future. All right, with that, thank you.
Thank you, Marianne. That was great. And thanks for sticking within your time. We have two more speakers on the cost topic, and then we move on to the other three topics. I'm going to go through all of the topics in one journey, and we'll start with questions after the 9 panelists have spoken. So please, participants, chat in your questions, put them in the Q&A, and we'll get back to them after we've gone through all the topics. The second speaker on the cost consideration topic is Anna Kaltenbeck, Senior Health Economist and Program Director from the Drug Pricing Lab at the Center for Health Policy and Outcomes at Memorial Sloan Kettering Cancer Center. Anna, thank you so much for joining us.
Great, thank you so much for having me. I really appreciate it. You can hear me okay?
Yes, you're fine, thank you.
Okay, so thank you again for having me here. I'm a health economist. I direct the program for the Drug Pricing Lab at Memorial Sloan Kettering Cancer Center. And it's sort of in that context of drug pricing that I want to make my remarks today, which I don't think are going to come as a surprise because we've already heard Dr. Wazinska lay out that framework for thinking about the right patient and the right time and the right place to give monoclonal antibodies. I think the others today have highlighted the health disparities and inequalities that really COVID-19 has laid bare. And that's kind of the challenge I want to address a little bit today in the context of cost and how to think about that in the context of putting that framework in place. So my comments are going to come really from the focus on the cost aspects of this problem. And my hope is that it can at least help point in the direction of some ways in which to deal with that. So I think maybe to level set, let me start with the very simple acknowledgement that the way that our healthcare system works, and it's setting aside completely this question of monoclonal antibodies or even COVID-19, the default setting in our healthcare system is that we use price as a way to ration care. Whether or not we acknowledge that publicly and whether or not that's how people view it, I think the reality of it certainly what comes out that way. And unfortunately, that really hasn't gone away with the pandemic. And so the provisions of the Relief Act, so FFCRA and CARES, that are meant to ensure that patients face few or no costs for testing haven't necessarily translated to the same in terms of treatment. The uninsured can receive care for COVID at no cost from hospitals that take relief funds, but there are real gaps remaining in the policy around treatment costs, and that can create a real barrier. So to understand the way in which cost interacts with all that, I think there's two factors we always have to think about and keep in mind. Drivers for costs are just the factors that modulate them and the way that patients experience them are where they get the treatment and who's paying for that treatment. So where they receive treatment, and that could be in the inpatient setting, outpatient setting, home care, long-term care. These are all reimbursed in different ways. And so they have different incentives associated with the use of drugs that are high cost. And that cost can get passed on to patients in different ways. So if you are getting treatment in an outpatient infusion center, it's possible that the patient would bear some form of co-insurance for the drug that they've received based on that price of that drug. Whereas if they were receiving that drug in the inpatient setting, it might actually get absorbed in a bundled payment from the payer to the hospital for that episode of care. The second element of this is what kind of health plan they're on or not on. And because those really, the benefit structures of those health plans determine the level of coinsurance that the patient ends up owing, and it also sets their out-of-pocket maximum. So stepping back to what this tells us about COVID, we don't know yet what the long-term financial responsibility is going to be for monoclonal antibodies. But there is, I think, a chance and a real risk to patients from a financial perspective here. Right now, Operation Warp Speed has secured 300,000 doses each of the Lilly and Regeneron products, and it's going to provide those for free, but I think it's very much foreseeable that more will be needed in the future, and it's not entirely clear as to how that procurement is going to happen. The other thing I want to point out, and I think is sort of an important element to keep in mind, is that the conversation so far has really focused on drugs that are being developed specifically for COVID-19. But that's not necessarily the only factor that we might have to contend with, because there's also treatments being investigated for complications of COVID-19 that are already on the market. Drugs like Remicade or abatacept that have been on for years, and they already carry a price tag. So there's a known entity there in terms of what their prices are. And they are also known to have very high prices that translate to high out-of-pocket costs. The other reason I mention this is because if we do go in a direction of setting a market price for these products outside of a federal purchasing system, I worry that these would serve as a pricing benchmark for products that are currently under the EUA. The reason I sort of want to bring these two things together is that obviously price sensitivity is an enormous barrier to any type of healthcare in the US, but it's, I think, especially important when we think about it in terms of COVID and in terms of thinking about it from disparities of care perspective. I think we know from experience to date that patients aren't always aware that they're entitled to free testing or free care. And that because they're unaware of it and expect high costs, aren't necessarily seeking care that they need to get. I think everything we've heard from this workshop gives us reason to believe that it's, that just coincides with the larger pattern of people falling through the cracks in this healthcare system, and those people being at higher risk for poorer outcomes and also having, higher health disparities. So that means by the time we get to a decision about who gets a Regeneron treatment or a Lilly treatment, that those who would actually stand to benefit the most from it have already been selected out. And that suggests that we need to be thinking about costs, not just from the perspective of the individual drugs, but really across the patient's journey from infection to testing to diagnosis and then onwards into treatment. I guess I would sort of want to anchor this all back to what we can get from these products. I think the greatest success that we can get from it is that they help level the playing field for those patients who are at a disadvantage, and that they alleviate the burden on our healthcare system and reduce the opportunity for transmission. I think if we look back and we said those three things about this product, I think that would be a success. But again, the issue is that default settings in our healthcare system impose costs as barriers throughout that patient journey. And so we can't rely on standard practice to make sure that we get there. We also have to acknowledge that the evidence is still evolving, and that means that we really don't know what the true value of these products is. So if we do go the route of pricing based on market standards, I think one of the real concerns I have is that we're basically asking people to pay for something where we don't know what the true value is. And doing that, especially in a disadvantaged community, really risks actually amplifying the disparities and causing financial harm that could be in place. So my thoughts on how to deal with this, I want to wrap it up quickly, but 3 things: take the cost off the table for patients. I think this is congressional action that's needed to harmonize benefit design out-of-pocket caps, aggressively and proactively communicate to patients that those benefits exist, and to providers as well, making sure that they know that that's there for them to rely on. And then I think also, to Marianne's point, offset the losses to healthcare providers who are bearing the sunk costs of scaling their infusion services. And then also at the same time start to, as a third pillar, really avoid recreating the incentives that are already there. Think about competitive acquisition, think about existing programs that we have that we could leverage if we're not going to use Operation Warp Speed for further procurement.
Thank you so much, Anna. A lot to think about there. Really appreciate it. Our third and last speaker on the cost topic is Brian Nyquist, President and CEO of the National Infusion Center Association. The floor is yours, Brian.
Thank you, Dr. Berwick, and thank you, standing committee members, for hosting this important workshop and for the opportunity to speak on other cost-related considerations impacting the integration of COVID-19 monoclonal antibody therapies. Specifically, I will speak to the total practice costs associated with furnishing infusion services and the underlying cost reimbursement disparity that is contributing to reluctance among community-based infusion providers to invest in expanding infusion capacity to accommodate these COVID antibody therapies. In NICA's conversations with non-hospital infusion operators, as well as various states, we've identified at least 3 factors that may be contributing to delayed uptake and integration of these COVID antibody therapies. 1, prescriber difficulty in identifying sites that have received allocation. 2, the lack of clear and consistent guidance in terms of infection control and infrastructure modification and the resulting impact on provider confidence. And 3, the underlying cost reimbursement dynamics that disincentivize investment in advanced infection control related infrastructure necessary to expand infusion capacity to furnish these monoclonal antibodies to COVID positive patients. Under current methodology, there are 2 payments that comprise providers' reimbursement for furnishing provider administered medications like monoclonal antibodies under the buy and bill model, in which providers acquire and maintain an inventory of medications, then bill a patient's insurer under the medical benefit after administering drug from their inventory. There is a payment for the drug and a payment for the professional services associated with furnishing that drug, commonly referred to as the admin payment. Under Medicare Part B, the admin payment does not cover the total practice cost to furnish infusion services, creating a significant cost reimbursement disparity. Historically, operators have been able to attenuate this cost reimbursement disparity with the add-on margin of their drug payments. However, in the case of COVID antibody therapies, when the drug is provided by the US government, providers will not receive those drug payments because they will not take ownership of the treatment courses. So in the absence of CPT codes for observation, the established Medicare payment rate for furnishing these COVID monoclonal antibodies in a 2-hour procedure does not cover the cost of coordinating care for those patients, much less justify the risk and opportunity costs associated with either investing in infrastructure modifications needed to safely integrate COVID positive patients into existing facilities or building temporary infusion capacity. And as Connie Sullivan with NHIA indicated, due to a 1-to-1 nurse to patient ratio, this cost reimbursement delta is also an underlying challenge in the home infusion space. Community-based infusion providers have expressed interest in exploring models ranging from acquiring and retrofitting vacant retail space to supporting an on-site temporary pop-up model to supporting a regional collaborative pop-up model. However, the limiting factor is the availability of liquid capital to invest in infrastructure modification or in resourcing these pop-up infusion sites. If I may quote a community-based infusion operator, "We want to do everything we can to help our community through this pandemic, but if we go belly up in the process, then we're not helping anyone," end quote. Without external support through state or federal grants or specialized reimbursement arrangements to allow for break-even investment recovery, we anticipate continued reluctance across the delivery channel to place healthcare workforce, native immunocompromised patients, and the financial viability of their practice at risk to furnish these therapies to even the highest risk patients. If reimbursement under private, fully insured plans and self-funded employer plans will also be inadequate, it will further disincentivize any additional infusion capacity expansion required to meet the increased demand as patient eligibility expands. In conclusion, these monoclonal antibodies will be a needed stopgap to minimize the health outcome, quality of life, and societal burdens of disease until a sufficient proportion of the population is vaccinated to achieve herd immunity. We cannot afford to lose capacity across the infusion delivery channel, and infusion providers across the classes of trade are struggling to safely integrate COVID positive and non-positive patients, or struggling to operationalize temporary infusion capacity to maintain physical separation between those patient populations, while mitigating exposure risk among the frontline healthcare workforce. Across the board, infusion providers need resource support, standardized guidance, flexibility, and creativity to expand the number of safe settings in which patients can receive consistent, high-quality preparations of COVID antibody therapies. Appreciate the opportunity.
Brian, I appreciate you. Thanks for such a carefully prepared statement. It'd be very helpful. We've now had our 3 speakers about cost, but we're going to move ahead to topic number 2. And remember, we'll come back to cost in the Q&A. Any of you can raise questions about any of the 4 topics. So topic number 2 is the manufacturing capacity and the capacity to scale up supply of these treatments. Our first speaker is Andrew Adams, Vice President for New Therapeutic Modalities at Eli Lilly. Thank you, Andrew, for joining us.
Yeah, thank you to the organizers for the opportunity to speak today. Is my audio okay?
Yes, it's working fine.
Excellent. You know, we're really grateful to listen to the discourse over the last couple of days here at Lilly. I think the highlights on some of these really important issues of getting a medicine we all worked so hard on to patients. You know, it's important to us to make sure that all of those efforts weren't in vain and that we can really address COVID and as many people as possible under the EUA that we have right now. So I'm going to walk through at a high level some of the manufacturing and scale-up related issues that we faced with COVID and how we addressed those. And we'll be happy in the discussion to go into detail on any of these topics as people are interested. So, you know, it's important to state that for Lilly as a company, in addition to the COVID antibodies that we were able to bring forward and are now providing to patients, we actually have a number of other life-saving medicines that we also need to provide to people and continue to provide. And so since March, you know, we've also had to adapt our operations because our own employees making things like insulin, making things like our oncology medications need to be able to come into work. And this includes in our manufacturing sites where we've had to ramp up things like testing there and provide a safe working environment for people in our manufacturing sites. So that, you know, you can imagine is a downward pressure for us on the ability to crank out more of a new medicine on top of what those folks are already trying to work to produce in our portfolio. So our focus has really been, while making these new medicines, to keep our employees healthy so that they can continue to provide the whole portfolio of Lilly medicines. It's really important to state whenever we're talking about this that making antibodies is a really complex process. We need specialized people, such as scientists and engineers, and nearly 300,000 square feet of manufacturing space, 40 miles of piping, 50 processing vessels, and several controlled environments like clean rooms to manufacture things like monoclonal antibodies. It can take us up to 90 days to manufacture even a single batch of the active pharmaceutical ingredient and the drug product for a neutralizing antibody because it's a highly complex manufacturing process with carefully controlled conditions and numerous quality and safety checks. Usually, it would take us months or even years to prepare for and complete this process, and we wouldn't begin large-scale production until we know that a medicine is efficacious and likely will be approved for use. This is the typical process that we follow when we're making our normal portfolio of products. Obviously, in COVID, that needed to change given the unmet need and the speed that we needed to get the antibodies to patients. So to help meet the unmet need and the global demand, we expedited our process, but without compromising our quality or safety standards by initiating large-scale production when our first human clinical trials began. So we were making these antibodies at risk at large scale prior to getting the efficacy data, which formed the basis of the EUA, because we wanted to make sure if it was successful, we would have medicine to provide to patients. We had to assess our current production schedule and see what we could move or delay to make room for Bamlanivimab. This was challenging because we have to be mindful of not creating an impact on the supply of our other medicines, like I mentioned, which patients rely on every day. Once the decision was made on where we could manufacture the therapy at our API sites, then we had to complete what's called a tech transfer from our development group to our manufacturing sites. Typically, these tech transfers take about a year. We accomplished this for Bamlanivimab in 3 to 4 months, 4 times, each for a different manufacturing site. And we had several factors that made this tech transfer different. You know, the facilities must fit the process. For COVID, this was reversed, and our manufacturing site team collaborated really closely with our development team to ensure that the process fit the facility. This saved us 6 to 9 months waiting on long lead time equipment and engineering project work on our rigs. Materials can take 6 months to be delivered from suppliers. For this molecule, a materials team was put in place who were in weekly and sometimes daily contact with raw material suppliers to ensure that we could meet the material demand. And typically we have face-to-face kickoff meetings for manufacturing and development to start the tech transfer process. Obviously for Bamlanivimab, this was done virtually, allowing the tech transfer to kick off as soon as the sourcing decisions were made. Formulation and fill of drug product usually takes months or even years to plan for. We have extremely detailed processes that we follow when we're doing this. And for Bamlanivimab, we accelerated these processes. We added more people, we parallel processed things at risk in terms of the people and time we were investing into the process. We had to accelerate to take DS fill to finish pack in only 1 month. This is a process that usually is measured in multiple months. We leveraged technologies such as rapid sterility and used a centralized strategy to reduce analytical testing. We accelerated the use of secondary and tertiary suppliers to ensure continuity. And the cadence of our governance accelerated and moved from being monthly or quarterly to being daily sometimes to enable these decisions to be made. We also had to work closely with regulatory agencies to obtain appropriate inspections and other requirements that were enabling us to make the medicines. Another challenge we had was that the first batch of Bamlanivimab was made during a hurricane in the Northeast and our site lost power. Fortunately, our manufacturing sites are made to withstand hurricanes and quickly revert to generators when necessary. But I think it just highlights the extreme lengths that we've gone to in collaboration with a number of other people, including the NIH, NIAID, AbCellera, Junshi, and a number of other partners to make this happen. And so to quickly provide the treatment to patients around the world, we initiated large-scale manufacturing in parallel, even before data demonstrated meaningful therapeutic efficacy for Bamlanivimab. We anticipate that in 2020, we will supply 1 million doses of 700 milligrams of Bamlanivimab, with 100,000 that were available as early as October. So I think what you can see from this trial is the way that Lilly were able to do this as quickly as we did, and I believe the same is true at Regeneron, is doing a lot of things that we would typically do serially in parallel, working with partners and accelerating decision-making to bring the antibodies to patients as quickly as we're able to. Manufacturing, I think, will continue to be a challenge moving into the future, but it's one that in partnership with a number of other people, including Amgen, that we're addressing head on, and we hope to be able to meet the supply needed in 2021 and moving into the future. So that's the high level, and I'd be happy to take any questions in the discussion portion.
Thank you so much, Andrew. Congratulations on that, your agility as a company. Let me just say a spoiler alert at the end. I think maybe we should come back to you to talk a bit about what changes in the environment or anything else might increase your capacity to provide even more supply than the large amount you're already planning. Next, we have Ronald Cobb, the Chief Scientific Officer from Ology Bioservices Incorporated. And thank you so much for joining us, Ronald. We do not hear you, Ronald. Are you muted?
Am I unmuted now?
Yes, now we can hear you. Thank you very much.
I would turn the camera on, but I live out in the sticks of Florida and my internet is spotty. So if I turn the camera on, you might lose me completely. So thank you for inviting me to this meeting, Dr. Berwick. And it's been an honor. It's an honor to be part of this group, especially this esteemed group. I would like to, first of all, agree with everything that the previous speaker just talked about as far as what needs to be done to get antibodies to the patients as quickly as possible. But what I thought I'd start with is a brief overview of who Ology Bioservices is, because most of you probably have not heard us. So on the first slide is just a quick overview of who we are. We're a privately held CDMO in Gainesville. We are an advanced development and manufacturing capability for the DoD. Fortunately, we are designed to take things from early stage R&D all the way through licensure, which made this ideal for the rapid response to the pandemic. And I agree with the previous speaker as well, that a very experienced regulatory affairs group was very, very valuable to navigate through the FDA and to get some of our materials into the clinics as quickly as possible. And the next slide is just a quick overview of where we are and what our experience is with the COVID antibodies. We are currently developing a 2 monoclonal antibody cocktail. These will not be administered IM. We are targeting an intramuscular type administration, and we have quite a bit of data with other antibodies that we have in the process of developing, and also have some animal data with our anti-COVID antibodies with an IM injection. The antibody sequences were from Dr. Crow's lab from Vanderbilt. I think everybody is pretty much aware of who he is and the antibodies that he has developed. We are currently in phase 1 clinical trials with ours, and I know we're a little bit behind Lilly and Regeneron, and we plan to have an EUA sometime in the middle of next year. And I agree with previous speaker that one of the biggest things that we had to do as a risk mitigation was to have a separate and additional manufacturing organizations to help us out, because we certainly were not able to manufacture the number of doses that would be required for even for the clinical development of these things. Now, I'd like to echo what everybody else has said over the past couple of days. It's just unbelievable how fast the industry has moved, not only the antibodies, but the vaccine industry as well, from the identification of this pathogen all the way to the development of the antibodies as well as the vaccines. And finally, in the last slide, I'm not going to go through exactly what we did to develop these things. We did very, very similar things as what Lilly and what Regeneron has did, as far as not really cutting corners, but doing things in parallel and as rapidly as we could. Normally, as the previous speaker said, the process development would happen very, very quickly. We moved directly to clinical development or GMP manufacturing before we even had master cell banks made. And generally, the master cell banks take several months, 6 to 9 months to generate and characterize, but we went directly from the stably transfected pools to start making our phase 1 clinical material. And I'd be surprised if the other folks did not do the same thing. But I'd like to also echo what was said before, that our biggest challenge has been the raw materials. The single-use bags that we use for our manufacturing bioreactors, we use Accelerax, and they're at the 500 liter. We use a lot of 500 liter bags. Not only are we using these types of bags, but other folks developing the antibodies as well as the vaccines are using the exact same bags. And the vendors for these things were kind of hit out of left field. They went from very little manufacturing these bags to having back orders of 6 to 9 months. But fortunately, these programs have been rated, and our vendors, I'm sure the vendors with Lilly as well, have been very, very good about getting us the materials that we need. We meet with those guys, most of our vendors, twice a week to make sure that we have the materials that we need, not only the bags, but the resins, the media for the cells, also for all the buffers. They have bent over backwards to help us meet our timelines and to move things forward as quickly as possible. And I'm sure that Regeneron and Lilly and the other folks have had the same experience we have, but it has been a challenge because we're in competition with each other for the same materials. The other aspect that was fairly challenging for us and probably challenging for the other developers was the fill finish capabilities. We do not have fill finish capabilities. And again, we are in competition with a number of other manufacturers, not only for the monoclonal antibodies, but also for the vaccines. So it was very incumbent upon us to get our slots reserved as quickly as possible. We have them, and we are talking to these collaborators on a weekly basis to make sure that our slots are still there. And it's been key to keep those slots. The communication has been key with not only these vendors, but also for the vendors of the raw materials. Another key aspect that we found with the scale-up of production is to have redundancy in manufacturing capabilities. We, as a number of other places, do not have the capacity to make the number of doses that is required for the clinical development and commercial development as well. It's very important to have redundancies. We were quickly able to tech transfer our manufacturing process to a collaborator. They have significantly higher levels and scaled bioreactors to help us out with these things. And so that was key to help us move forward as quickly as possible. We already had a formulation that we had used with numerous other antibodies that was designed for intramuscular administration. So the formulation was not so much of an issue for us. Using our collaborators for some of the preclinical studies was also key for us to move forward very quickly. We did things in parallel just like everybody else did because the time was everything. One day slip meant people's lives were in danger. And finally, the last thing that I would like to say that could have been a challenge and has been a challenge for other vendors that we know of is just the disease itself and how it could spread among the workforce. We have put in several CDC guideline protocols that has helped us out quite a bit. We have had less than 2% of our population at the facility come down with the disease, so we have not been impacted. However, we do know that some of our vendors have been impacted, and that has put some challenges on getting us the raw materials, also put some challenges on us getting some of our preclinical studies done in a timely fashion. And with that, I will close and wait for questions at the end of this session. Again, thank you very much for inviting me.
Thank you for joining us, Ronald, and for that great orientation to your work. So we've done two topics so far, cost and then scale up. Now we're going to turn to topic number 3, which is a big one, evidence generation and data considerations. Our first guest is Samir Al-Sari, Associate Executive Director at Permanente Medical Group. Samir, please, the floor is yours.
Thank you, Don, and thanks for inviting me. Can you hear me okay?
Yes, I can hear you just fine.
All right. I guess, are you able to see the video? Someone's asking me to turn it on, but I think it's on.
Yes.
Yes, okay, perfect. So I'll just start out by saying that the COVID-19 pandemic has really been tough on our population and on our healthcare and essential workers. And our population is really tired of non-medical interventions, even though they work. And when potential therapies are available, they give us a lot of hope. And what we have to really do is balance between giving hope and making sure that we have adequate data regarding a potential therapy. So as you all know, the BLAZE trial for, I have trouble pronouncing this, Bamlanivimab, I call it BAM, was published in the New England Journal of Medicine, only had 233 patients in the treatment arm. And although the study did not meet the primary endpoint, which was looking at viral load differences between therapy and placebo, there were some secondary endpoints that suggested modest evidence in reducing ED visits and hospitalizations. And so the FDA, whose job is to make sure things are safe, gave an emergency use authorization to this investigational therapy. And even though these antibodies were really not tested at that time in anyone below the age of 18, they actually gave an indication to the age of 12. And so these antibodies are a scarce resource currently. They come down from the feds to the states to the counties, and then finally local health systems and providers have to kind of ask for some of these, and sometimes we get them. And once we get them, it's kind of difficult to even figure out how to give them because we have a limited supply of the antibodies. And in the last few weeks, we had hundreds of patients, and now we have thousands of patients who would actually meet the emergency use authorization. So I just have to say I'm lucky to be working in an integrated delivery system, Kaiser Permanente, where we have all of our specialists together. We have pharmacy in-house, we get our labs in-house, and we actually have an electronic medical record that helps us track things. And so typically most of our patients get their labs done inside of our system. So we were able to rapidly get data on people who had tested positive. We had to actually put together a team of people to review all of the positive patients, and it had the right medical subspecialists and pharmacy and nursing and even ethicists to take a look at this limited scarce resource and how to then infuse it. And then we had to set up all the right locations to infuse these things. Initially, we said we'd do it in our emergency rooms, but they were really busy. And so we had to actually set up infusion areas in our outpatient settings away from our regular infusion clinics, which had our cancer patients and our immunocompromised patients, who we didn't want to expose them to COVID positive patients. So it took a lot of time, and on a daily basis, I would say it takes even 2 or 3 hours to review the number of patients who've tested positive and try to figure out who would get this limited supply. And to make it even more interesting, the National Institutes of Health and the Infectious Disease Society of America are both currently not recommending these antibodies as a standard of care. They actually say that the level of evidence at best, I'm quoting them, warrants a shared decision-making conversation between doctor and patient for a therapy with unknown efficacy. So again, we had patients, when we're having these shared decision-making conversations, refusing. And so you have to kind of go down the list to see who else might be available to do that. And then again, as an integrated delivery system, we have to figure out, do we divert nursing resources and physician resources to the infusion clinic, or are we using them in the emergency room or the hospital? So I think it was problematic for us that the data was limited. The efficacy data is modest. The shared decision-making is pretty complex. And then actually the administration of the drug itself takes an hour, and then watching our patients takes another hour. So our physicians always love to have data. And so currently we are actually collecting data on all of our patients. Of course, it's not a randomized double-blind study, but we're essentially collecting data on our patients to see what has happened with safety. And eventually we could take a look at seeing, did it affect whether they ended up in the emergency room or hospital. And I believe we have almost 230 patients. So that's similar to what was in the treatment arm for the BLAZE trial. So as an integrated delivery system, I think it would be great to have these new therapies that are available. But again, it is really important to have data that shows the efficacy. Because in the current state, it really was difficult. We had physicians and even some of our pharmacy and therapeutics people said, hey, if this came to our formulary committee, we would probably refuse this. And I said, well, yes, but this is an emergency use authorization. And that's sort of the only thing we currently have as these new therapies are coming out. So I'll stop there and hold off till the Q&A part.
Much obliged, Samir, and thanks for your careful recitation about the underlying science. It's really helpful. Our next guest, also on topic 3, evidence generation and data considerations, is Natalie Dean, who's assistant professor of biostatistics at the University of Florida. Please proceed, Natalie.
Hi, everyone. Thanks so much for having me. So I've been invited to give some remarks about evidence generation. A little background on me is that since its inception, I've been working with the World Health Organization's R&D Blueprint Initiative as part of the group talking about clinical trial norms and standards for evaluating new vaccines and therapeutics during the context of public health emergencies. And through really extensive discussions with this group, I've really found that all roads lead back to rigorous evidence. And for example, the lack of recommendation from IDSA and NIH, I mean, whether that's the intent or not, can be interpreted as a lack of support. And physicians really look to these bodies for validation. And as we heard yesterday and with our previous speaker, if physicians are hesitant to prescribe the treatment because they're unsure of the risk-benefit profile for their patients, well, this represents a really important barrier to use. And there is a concept of an evidence limbo, and we really must be mindful of this. So with that in mind, I prepared 3 major points about a path forward for generating evidence in this setting. The first is really to start with the end in mind. And sometimes I think there's an inclination to collect data, stand up a study and just try to learn from it later. But I'd really strongly recommend linking the data and the analyses to a very clear set of hypotheses. This could be to identify which group experiences the greatest absolute benefit on a clinically meaningful outcome. It could be to validate a flow diagram or a risk scoring system. It could be to identify biomarkers that provide substantial additional predictive power for predicting risk or predicting benefit over just some basic demographics and medical history. The key, though, is to really link data collection and analysis to a decision, and to, as much as possible, really pre-specify what that framework and what those options look like. Data in support of a clearly defined hypothesis are more likely to be viewed as rigorous, reliable, and robust, and that's what we need in this setting. The second point is the importance of a control group. A control group really underlies all of our calculations of benefit. Particularly, we're looking for prospectively identified individuals to really make sure that the proper covariates, eligibility, outcomes have been collected. Because again, we're looking for high quality evidence. And actually, there are some nice opportunities here. First, the random allocation framework or lottery system is basically a natural experiment that you can use if you go ahead and collect data on those who are not selected. But even if you get to a point where there is sufficient supply and 100% of people are able to receive the treatment, there are other options. I'll flag one particular design called the regression discontinuity design. Basically, the idea here is anytime you have a threshold that determines eligibility, you can compare people that are near the threshold but on opposite sides of it. So for example, if people must be within 10 days of symptoms in order to be eligible, the people who are 11 days, are they that different? And so we can start to think about these types of what we call quasi-experimental designs in order to continue evidence generation. So there are a lot of approaches, but basically now is the time to think about those and make those plans. And my last point is the importance of harmonization across studies. I think 2020 has really been the year of the mega trial. A UK recovery trial comes immediately to mind. And we've seen the strength of collaboration. And when we think just about how evidence accrues, studies that leverage large networks of sites are really able to generate results more quickly since they're all contributing to the same pool. And then we don't need to wait for individual studies to finish before we combine their results. Nonetheless, we continue to see a lot of single site trials. And so in the interim, where we don't overcome that challenge, we can at least ensure that study methods, particularly outcomes, are standardized. So to that end, convening expert groups to discuss the different options, make recommendations, sharing protocols, and starting to plan out what a meta-analysis might look like. These are all very valuable strategies. So those are my 3 points, starting with the end in mind when you're standing up a study, carefully selecting a control arm, and harmonizing methods across studies. So thanks again for inviting me and particularly for soliciting a biostatistician's perspective. And I look forward to the discussion.
Perspective is essential. Natalie, thank you very much for those clear remarks. We're now in this rather fast-paced multi-topic session going to turn to our fourth and final topic. That is a kind of global view. We're going to try to extend our vision a little bit outside the US. First guest is Mark Feinberg, President and CEO of the International AIDS Vaccine Initiative, the AVI. Mark, thank you so much for joining us.
Thank you very much. Happy to be with you, and it's great to be able to participate in this discussion. Can everyone see my screen?
Yes, we can see it.
For those of you who are not familiar with IAVI, we're a not-for-profit product development organization that focuses on HIV, tuberculosis, and emerging infectious diseases. We develop vaccines and monoclonal antibodies with a specific interest in challenges present in low and middle income countries and a core commitment to access. We have actively ongoing COVID vaccine programs, which is now in clinical trial through a partnership with Merck, as well as a COVID monoclonal antibody program, which is about to enter the clinic with a specific goal of products that would have cost structures and profiles that might increase their ability to be implemented in low-income countries. I think, as everyone knows, by definition, a pandemic is a global threat. All of the discussions today have really highlighted challenges of monoclonal antibody implementation in the United States. But if you think about it, these challenges are going to be as severe, if not even more pronounced, in many countries around the world, and particularly in low-income countries or many middle-income countries where healthcare infrastructure is less sophisticated even than in the United States. So there are really a number of challenges here. Clearly the advent of efficacious vaccines is really a tremendous advance, but that's really only going to be primarily beneficial, at least in the near term, in higher income countries. And we anticipate that vaccine rollout will take longer to reach countries of lower economic status, which means the pandemic will persist in lower income countries for a longer period of time. A lot of effort has been focused on repurposing older and expensive drugs as a hopeful solution to addressing LMIC challenges. But I think, as everyone knows, with the exception of dexamethasone, the only drug that has been shown to be, that is the only drug that's been shown to be efficacious, and all the others have failed. And it's really likely and unfortunate, but true, that innovative, more efficacious vaccines, but that are more complicated, like monoclonal antibodies, and more expensive, will likely reach LMICs last, if at all. We've been interested in this issue of global access to monoclonal antibodies for some time, and have been working with the Wellcome Trust to really frame out this issue. We started this effort, and there's a publication that you can all review that's listed on this slide that really addresses gaps and opportunities for increasing equitable access to monoclonal antibodies in lower income countries. And when we started this work, we knew nothing about COVID, but COVID obviously was a primary test case for this. The bottom line, which I don't think will surprise any of you, is while monoclonal antibodies have really transformed modern medicine and accomplished many amazing things in the fields of cancer immunotherapy or treatment of autoimmune diseases and many others, and by virtue of the fact that they're commercially successful in addressing very serious diseases, they also now represent a significant proportion of the pipelines of many pharmaceutical companies. So this gap in access that currently exists between high-income countries and low-income countries is only going to be more pronounced with time. And the bottom line is that there's really next to no access to life-saving and life-improving monoclonal antibodies in low-income countries and many middle-income countries. And the gaps are really around awareness, unclear regulatory processes, unclear market sizes. Even the standard procedures for WHO pre-qualification and policy decisions are not well established for monoclonal antibodies. There's lack of donor-funded procurement mechanisms, and there's really not existing business models that can make monoclonal antibodies at scale and at an affordable price point for low-income countries. And all of these will need attention if we're going to have greater, more equitable access to these very innovative products. In the report, we did address the COVID situation and thought that this would actually be the vanguard that might actually help us, pioneer greater access to monoclonal antibodies in low and middle income countries. But I think, as we're seeing, there are many challenges to realizing this vision, and I just want to talk about some of them. One of them is obviously the product profiles that are making it challenging to implement the products, even in the US, are going to be even greater in many other countries countries, including the high doses that are utilized in the available products available under EUA. The requirement for intravenous infusion is going to be even more daunting in countries that have less sophisticated healthcare infrastructure. Cold chain is a major issue, as we all know. Clearly for delivery, given emerging data that clearly suggests the monoclonal antibody efficacy is greater in earlier rather than more advanced disease, indicates that linking diagnosis to care in an expeditious manner is going to be fundamentally important, and that means that the healthcare systems need to be prepared really to have a public health response that currently doesn't exist in many countries. Clearly, affordability is a key issue, and this issue is exacerbated by the high doses used, the complexities of manufacturing that you've heard about, and the cost of administration, which is also going to be an issue in lower income countries. And clearly the supply is insufficient even for the United States, but of the global supply, remarkably and in a rather inequitable way, almost all of the early supply is committed to the United States. Obviously, we have a problem here, but COVID, as we know, is a global issue, and the scale of manufacturing is not nearly sufficient to meet the global demand, especially when you're talking about high doses, and at least for one of the products and some of the other products in development using more than one monoclonal antibody. If you look at where the world is in terms of investing in access to monoclonal antibodies and other COVID therapeutics, it's really a fairly disappointing picture if you look at the ACT Accelerator Therapeutics pillar, which is the main mechanism for global access. They've targeted $6.6 billion in need through the end of next year, which is reduced from what they had said previously because they've experienced difficulties mobilizing the resources. And to date, they've only mobilized approximately $460 million for all therapeutic modalities, and there's a $6.1 billion gap, of which a significant portion is needed early. And if you look at the chart, the pie chart, only 4% of global investments addressing global needs have been focused on therapeutics. There's a lot that needs to happen to enable access in low and middle income countries. We need better product profiles. If subcutaneous delivery or intramuscular delivery works in terms of pharmacokinetics and pharmacodynamics to treat this infection, that would be very promising, but that requires additional R&D, which is now underway. We need to address the affordability issues, and obviously being able to demonstrate the lower doses are equally efficacious will be important, or using more potent antibodies. We need alternative business models to address global needs, and we clearly need to scale up manufacturing at a very significant level. Obviously, there's a lot of clinical, regulatory, and policy issues, as well as procurement issues that need to be addressed, and currently really are not the subject of significant ongoing activity. So if we're going to be successful, we're going to need greater political will to champion innovative access to innovative COVID therapeutics beyond wealthy countries. We're going to need an integrated public health response that prioritizes vaccines but isn't solely focused on vaccines. We're going to need investments to drive innovation to make the products more relevant to low and middle income countries. We'll need business model innovation, and we'll need attention to healthcare delivery systems. Obviously, there's a lot to do. For those who are interested in hearing more about this topic, I refer you to this upcoming webinar hosted by the Wellcome Trust, Unitate, and IAVI on January 19th. Thanks so much for the opportunity to participate in your—
Thank you, Mark, and thanks for IAVI's extremely important work, and I really appreciate your being here. I know how busy you are. That brings us to our last speaker. We saved the best for last. Charlotte Taylor is joining us, Acting Director of Therapeutics Task Force in the UK Department of Health and Social Care. I need to say that Charlotte was able to sign on at the very last minute. And Charlotte, your agility and your willingness to join us was very short notice. I really, really appreciate it. So the floor is yours, and when you're done, we'll move to questions.
Great, no, thank you so much for the invitation. Of course, the thing about going last is an awful lot of what I was going to say has already come up in various of the comments already. I'll start by saying that a key principle of access in the UK's National Health Service is that treatment is free at the point of access. But of course, that doesn't mean that everything is available to everyone. So our approach is very much driven by the evidence, which is obviously always important, but even more so in respect of therapeutics, as they're both in short supply and very expensive. I think another panelist sums it up really well in saying the challenge is to identify the right patient at the right time and in the right place. I think that's something that we're grappling with at the moment. We're really keen to understand which patient cohorts would benefit most, and in particular where in the disease progression is the most effective intervention. At the moment in the UK, antibodies are only being used within trial context. Notably, the Regeneron antibody cocktail is currently being trialled in our recovery trial, which I'm sure you're probably aware of. It's a very large randomized control platform trial. As of last week, we had 20,000 patients enrolled into that trial. About a third of those are into convalescent plasma. And obviously the number going into the Regeneron arm is much smaller, but that's in part due to the complexity of the administration and the exclusion criteria that we've got in place. We're obviously watching trials in other countries, other cohorts with really keen interest, but we are really keen to make sure that the use in the UK stays within trials so that we can gather information, which this also supports the regulatory process for the longer term and wider use. A number of panelists have mentioned the complexity. This is a real constraint in the UK. We don't have a large infrastructure for outpatient IV administration. And as we're exploring our options, in particular for prophylactic use, but we have real concerns about how we can deliver this at any real scale. So we're exploring other cohorts, particularly patients who might not be able to take a vaccine. That was one of my other points I just wanted to make. You know, we're in the UK, we are in a fortunate position of being in the middle of a vaccination rollout program. The rest catch up sooner. But it does mean that we need to set our strategic approach against that backdrop. We began vaccinating 10 days ago, and we've got about 140,000 patients have already received their first dose, and we're ramping that up as quickly as possible. Obviously, a lot of those patients who have received a vaccine are the patients who, if they had come down with COVID and needed treatment, would have been prioritised by risk and would be more likely to have received antibody therapies if they had been eligible. So, you know, our whole approach has shifted incredibly quickly now that we're in the position of vaccination. And of course, you know, antibodies are significantly more expensive to buy and to deploy than vaccines. So just to sort of summarize there, you know, we've got a very clear evidence-based approach. And I think it's important that everyone continues to generate the data and that we share that data as quickly as possible so that we have a shared understanding of where the benefit is clearest. Practical considerations and our limitations in deployment as well. And again, sharing those lessons as we all navigate this new territory is incredibly important. Thank you.
Thank you, Charlotte. I think the importance of global learning here has never been higher. I really appreciate your joining us. We only have about 10 minutes or 12 for questions, and I apologize for not having been a better timekeeper. I think that what I would like to do is ask a few questions that I've kept notes on. I've watched the chat, and I think these would be consistent with what you want me to address, and I'll try to pick up a few more questions, especially if you can help me, Lisa, identify questions that have come that I'm not addressing. So I'm going to do it panel by panel. The first questions about cost. I have a couple that have occurred. Several of you mentioned the inadequacy of the payment system as currently established to cover costs, especially in smaller institutions. Should there be a separate budget system for capital costs to kind of be able to allow systems to set up the infrastructures they need? Have any of you thought about that? And please, may I ask you with all due respect to keep your answers really short because we have to go through a number of the panels. What about, should we separate the capital from operating costs and find a source of capital directly?
As I can jump in and try to address that first. So I think the answer would likely be yes. I think that might be an easier source of funding support and resource support than trying to adjust the Medicare reimbursement structure. which may require an act of Congress. And if that is the case, then absolutely other sources of external funding would likely be more viable.
Any others want to talk about that cost recovery point?
Just to add that I agree that that would be a good resource, but at this time, it's just trying to figure out where that funding would come from is less certain. And I think if there are to be further discussions about how we could define what that amount would be needed, and then where there would be a willingness to pay, I think would be a great path forward, but one with a lot to be figured out.
Great, thank you. The capacities we're developing, infrastructural capacities, Brian, are these multiple use capacities? They be bespoke only for the monoclonal antibody administration? Are we building it? Are there more general uses for capacity development?
Yeah, I think long-term, if we're talking about infrastructure modifications within existing permanent facilities, I think there is long-term value and benefit associated with some of those infection control related infrastructure modifications. I think some may be less useful, but I think if there is external funding support, clear guidance across the states in terms of what type of infrastructure from a biosafety infection control perspective would make sense to support the safe integration of COVID positive patients with native non-positive patient populations, I think we could find a good balance and sort of compromise there. One example, if we incorporate some sort of HEPA filtration in the air handling, I think that could be conducive long-term, right, in treating potentially infectious patients, whether it's seasonal flu or cold or whatnot.
Thanks a lot. For Andrew and Ronald, Andrew, you estimated you'll get about 1 million doses in 2020. Is that it? Are we at our limit, or is there anything that could happen infrastructurally in terms of other kinds of environmental changes that would allow, let's say Lilly as an example, to produce even more, even faster, or are we just at the limit now?
I think for 2020, because obviously these products have a fairly sizable lag period from when you start the manufacturing of the batch to when it's available. I think the 1 million in 2020 from Lilly is likely the top end of what we're going to be able to provide this year. In 2021, we expect to have greater capacity, given again, like the rolling time frame to make batches of the antibody. I think it's important to remember though, that I think we have to be sensitive to the environment, that there may be with vaccination, and we hope this as much as anyone at Lilly, less of a need over time for the antibodies. And so I think figuring out what the appropriate amount of antibodies to make after we get through this winter, where we will have a largely unvaccinated population, that's something we're keeping a close eye on, because hopefully what we get to is only a need for those who, for whatever medical reason, cannot be vaccinated, or people who are immunocompromised. Perhaps those are the folks that we focus the antibodies on in future. But I think next year we expect to be able to significantly increase supply until the vaccinations really are rolled out globally at this point. And I think that the other important point is for low and middle income countries, we signed the agreement with the Gates Foundation, but we still agree, and with the points that were made, it's very difficult to roll out things like monoclonals to those countries in an intravenous cold chain format. So lower doses and subcutaneous injections are still things we're working on, and they will also bring down the demand on the manufacturing side too.
While you've got your attention, Andrew, and feel free to weigh in. Are there any game-changing technologies with respect to monoclonals that you see on the horizon now that would change the need for the kind of infrastructure we're talking about for, say, safer preparation or intramuscular forms, or is this the technology we need to be engineering for the next few years?
Yeah, I mean, the two first-gen approaches, ours and Regeneron's, are both human IgG1s. I think other people are exploring different antibody formats that can perhaps be easier to manufacture at larger scales and maybe amenable to lower doses. Unfortunately, I think there's going to be a lag sort of clinically until we have the data to support those. As you know, we also still have a number of ongoing studies. So also to address that question that came up earlier, we hope to be able to provide more data And also importantly to us at Lilly is providing data in the long-term care facility setting. I think we agree that's a really critical population, and we hope to read out our study in that setting in the coming months too. So I think some of these novel formats though are really potentially attractive. You know, you probably read about Regeneron and the lung gene therapy approach that they're potentially considering with UPenn. I think pushing those boundaries could be useful not only for COVID, but also for future pandemics if we have interesting technologies we can deploy quickly. So we're looking carefully to see where that will go.
Thanks so much. Well, that gets us to data. Let me ask Samir and Natalie. I have one simple question. Maybe I already should know this, but do we need a national database rather than a distributed or state level one or institutional one, and will we have one? And I guess the implication is, are there barriers we should know about if the need is there? What are your views on that, Samir and Natalie? I think you might be muted.
Sorry, unmuted. National database in terms of tracking patients, you mean, or?
Tracking patients who receive the monoclonals and studying effectiveness, complications, patterns of use, and so on.
Yeah, I think we need some data. You know, everybody's sort of putting things together themselves. And I'll tell you, at least in our EHR, we've been tracking all of our COVID positive patients and reaching out to them. And we've been able to have our own risk stratification system based on age, BMI, diabetes, all of the usual things that you see. And we can actually predict who's going to end up in the ER versus our lowest risk patients actually only end up in the hospital or ER 1% of the time. And so some of our physicians wanted to use our own criteria. And I said, no, you've got to actually use the EUA that's come out with. And so having some sort of a national database tracking these people and outcomes is going to be critical for using these products.
Thank you.
Yeah, and I just add, you know, that the U.S. just is definitely at a disadvantage in the sense that our electronic, you know, health record system is not standardized. I mean, we look at the UK and what they've done with the recovery trial, and that really, you know, it reflects a lot of things, but it definitely reflects also an advantage in having that standardization. So.
Thank you. Well, on that score, Charlotte, and please Mark comment as well, are the international learning systems adequate now that the ability for countries to exchange information on the use and performance of these medications, or do we need to take our attention further into that?
Charlotte, do you want to go first?
I think it's probably one of these areas where we can always do better. I think it's probably better in this pandemic than it ever has been before, but there's still room for improvement, would be my short take on it. What do you think, Mark?
Well, I think in many lower and middle income countries, they're close to non-existent, particularly in having any sort of informative way to, you know, garner and analyze information. And there's a need for significant awareness and investment in that area as well.
Thank you. Mark, do you have any estimate just offhand, just from Yavi or otherwise, about the total global need for these products? Like how far are we from current production and what the total need would be if were ideally meeting it?
Well, I think, yeah, I mean, that's been part of the problem is, you know, clearly if you're going to be preparing for global access, you need an understanding of what the actual global demand is. And this has been such a dynamic area. You know, no one really could have had confidence that we would have highly efficacious vaccines available as quickly as they've become available, which, as Andrew mentioned, has an impact on what we think the demand forecast is going to be. Also, as I think everyone knows, there are some promising small molecule antiviral drugs in development that could obviate the need for monoclonal antibody therapy. So it's been very difficult to make a projection about the global need. And I think that's been one thing that's impaired people's willingness to make meaningful investments in this area. So it's really kind of, you know, we won't really know until we give it a try, but whether we'll be able to get the sort of global access goal out of the gate or not, I think is an open question right now, which is disappointing because we know this isn't going to be the last time we're going to have to deal with challenges like this.
Thank you, Mark. And thank you, the whole panel. This has been a remarkable panel, and a little bit breathless, I fear, through the design that I implemented here, but I really do appreciate it. We've got a lot to chew on, and you've just been great and so responsive and well prepared. I'm very grateful to you. Wish we had another hour to go into questions, but we don't. So let me thank you and turn it back over to you, Harvey. Thank you very much.
Don, thank you for your exceptional moderation of a truly exceptional panel. This has been a remarkable journey over the last 2 days. And I know we have a lot to absorb and a lot to think about. I would like to invite Chris Hassel, if he's available, from the Assistant Secretary for Preparedness and Response Office. Chris has been such an incredibly strong and effective partner with us at the National Academies in this, as well as many other efforts related to COVID. And Chris, I would welcome your comments if you would care to offer any at this closing.
Thank you, Harvey. I've been, ever since this standing committee was stood up, I always looked a little speechless afterwards because they're so valuable, and that this is, I think this is, you know, a golden example of that. So for everyone who put this together, first of all, we appreciate it, and more importantly, everyone who participated. And I'm sure a lot of people are not on the line now who've been on the whole discussion for the last 2 days. But you know, getting so many valuable perspectives, and then the discussions that ensued from those different perspectives, is going to be incredibly valuable. We're having to, and the reason I wasn't able to be on many of the, or much of this whole 2-day session, was because we're actually in the midst of making decisions now. But this is still timely because this is still going to be with us for a while, and there's plenty of time to adjust. So a lot of what we've heard the last couple of days, I'll be going through the transcript in much more detail, perhaps even reaching out to some of the people because to explore a little bit more. But the fact that, you know, there were so many perspectives, like I say, the state and locals, so many other stakeholders. I'm just going to pull one example, since rather than exclude a few, I'll exclude everybody except one. But the fact that you brought the transgender community perspective into this, it's just one example of something that we need to make sure we're taking into consideration, along with all the others. So I know for the committee members and for Harvey and the staff, I'm sure this has been quite an undertaking. So we very much appreciate it, and I promise you this will not have been a wasted effort. We will make use of it. I'm conveying this message on behalf of Bob Cadlick, who's the ASPR also. He was very pleased this is going on, and this is a particularly important issue for him and for all of us, but he's taken a particular passion because of the potential for some of these therapeutics to attenuate the huge pressure that's on the healthcare community right now, and the difficult decisions are going to be made if we can't bring this a little bit more under control while we're seeing the rollout of the vaccine. So this is extremely timely. Thank you all very much again, and I'll turn it back over to you, Harvey.
Chris, it's a pleasure to have you with us and always to work with you. We're so appreciative also of John Redd along with Bob Cadlick at the office. I do want to make a special mention and thanks to the redoubtable Lisa Brown and her colleague Emma Fine, who on the staff of the National Academies and on behalf of our committee did really the heavy lifting in organizing this session. We've covered a lot of territory in this couple of days. The problem, the challenges of allocation and use of this precious resource of monoclonal antibodies, we've talked about really at 3 levels. We might think of it as a macro, a meso, and a micro level. The macro level for the nation is the distribution from the federal level to state level. The meso level is the state to site distribution, and the micro level is the site to patient allocation. And we've had, I think, important lessons and implications for all 3 of those. For example, even at the national federal level, as effective and useful as the core model has been, there have been a number of comments that would re-emphasize some of the exploratory and additional special channels that are being developed and implemented, such as with the Indian Health Service or direct channels to the federally qualified health centers and to prisons. These are all important innovations at that level. We had a tremendous range of explanation and discussion of the formulations at the state level, and we'll come back to that in just a moment, and a great deal of focus on the rules and bases, the principles and the actions on the ground that lead to the allocation to individual patients. So as a first point of summary, I think we can take away, we need to be thinking about all three levels of distribution. The macro, federal to state, the meso, state to site, and the micro, site to patient. Secondly, underlying this entire discussion, almost like a background basso continuo in a musical composition, has been the core levels of ambiguity and uncertainty about the efficacy and the recommendations for use that underlie the deployment of the monoclonal antibodies. This in turn has implications and questions for the use of emergency use authorizations. We have talked about the statements from the NIH and from the Infectious Disease Society of America that describe monoclonal antibodies not quite as the standard of care, not quite for routine basis. And it's not 100% clear how much of the ambivalence is grounded in uncertainty about the evidence for efficacy, and how much of it is actually conditioned by a recognition of the shortage of production capacity relative to the potential demand. And this has been a backdrop to our discussion. A third point I would offer is what we might call the paradox of unused supply with a relatively scarce product. This is what we heard about as localized mismatches in the distribution and availability of the monoclonal antibodies versus the needs in different settings. And there are not clear explanations completely to understand these mismatches, but they raise an opportunity and a challenge of implementation, of communication. Personally, I would like to learn from whoever that pharmacy representative is in Ohio that is getting 95% of the candidates and more to enter treatment in a timely way. I think we probably all could learn something about communication to patients from that individual. But altogether, this mismatch of supply and use is a striking and, in a way, surprising revelation from the discussion over the last couple of days. A fourth, and I think very importantly, this topic for us has opened a window on a whole set of pervasive underlying problems, challenges that beset society and the healthcare system, particularly here in the United States. They begin with the problems of racism, chronic discrimination, disadvantage to a range of groups by ethnicity, by sexual preference, by age, by all of the things that we've talked about. Secondly, the fragmentation in our healthcare delivery system, which exacerbates the challenge of getting effective treatment out, and how different it is for an organized, community-oriented system, such as we heard from Geisinger in Pennsylvania, as contrasted with the challenge of a fragmented and disconnected set of providers. Third, the fragmented payment system, which also at the present has not provided adequate support to cover the cost of the delivery of this service, and we heard about that problem. That's capped and matched with chronic underfunding and restrictions on use of funds that we heard about for federally qualified health centers, for community health more broadly, for the public health infrastructure as well. Another chronic underlying issue is the capacity of production for agents such as this. And these are partly technological, they're partly organizational, they're partly matters of process and supply, but they represent a very important challenge that underlies a lot of our discussion. And finally, we could point to the tension between domestic priorities and global needs that we talked about in this final session. A fifth general observation that I alluded to yesterday about the variation in the ways in which states especially and local institutions have gone about the distribution, coupled with a continuity or consistency in the kind of principles that they have relied upon. But that discussion was refined in a very important way through the course of our second day's discussion, so that the three basic models that have been deployed to identify the candidates for this limited supply of treatment. The first being the notion of refining your selection criteria. For example, limiting the number of days since diagnosis beyond even what the EUA specifies, but refining criteria to try to get to the most needful patients, or the patients most likely to benefit. This really stresses and puts high emphasis on the criteria of maximizing benefit. Then we heard about models that use set-aside categories for making a certain amount of the drug available in certain settings or to certain populations. That tends to put greater emphasis on the equity part of the criteria. And finally, the ideas of lotteries and weighted lotteries and other matters of selection has a special stress on the value of fairness and the appearance of fairness. So we've seen in the varieties of choices that have been made an opportunity for a great deal of mutual learning and for understanding the bases and the practical application of these different approaches to making the final connection between the available drug and the patient who will receive it. I'll just wrap up with a few comments on challenges ahead. The first that I would highlight, Dawn and others talked about at the end of the last session, the need for continued learning and understanding at multiple levels, the overall effectiveness, the advantage and potential for benefit for different patients, refining those criteria, localizing them, understanding how they apply. We had a very helpful discussion about the opportunities for generating evidence, whether from the lottery systems, from colleagues in other countries, from data gathering systems and registries within our own country. But a big challenge in a continuing way is ongoing learning. Secondly, improving the linkages between a test result, a process to select patients, and an actual delivery. And maybe there's opportunity for this distribution to be improved. I could imagine the triangle between the infusion community of experts, long-term care facilities, and health centers in communities acting in concert to develop improved models for connecting the pieces from result to criteria to patient, moving across to get the needs met where they exist. We can third think about refinement of the various models for distribution at the federal, state, and local level, much as I have already mentioned. Fourth is to be really looking harder at the payment model that could spare out-of-pocket costs to make the funding sufficient to cover the actual costs when we have, at the same time, optimized the efficiency of delivery. In closing, I would just say it's sometimes said, do not let the perfect be the enemy of the good. I would say we should not let the perfect be the enemy of the better, of working to improve, even when we may not be able to reach the optimum solution. Can we, and how can we, improve from where we are today? That's the takeaway message and core lesson from these 2 days of workshop. I just want to close now by thanking again all of the participants, the moderators, the organizers, and all who attended for your input along the way. If you have additional feedback or comments, we most cordially would welcome hearing from you. Most efficiently to connect through email as shown on the screen with Lisa Brown, lbrown@nas.edu, and Emma Fine, EFINE @nas.edu. Thank you all very much, and Godspeed.